it's needed.
Hello, hello.
Hi, can you see me okay? See me, Zori Colombia joined. I will run some music until other people join. Chris and Anu, can you hear me okay? And do you see my screen? Hi, everybody. Thank you for joining the course. We'll wait a few minutes until the rest of the fellows and residents join.
Good afternoon.
Good afternoon, Dr. Baweja.
How are you doing, sir?
Wonderful. So we'll just wait for a few minutes until the rest of fellows and residents join. So
Absolutely.
5 minutes more or so. Dr. Baweja, you have nicer background than mine.
Beautiful day too, so I'm having a good time.
Wonderful. Missouri Columbia fellows, welcome to the course.
The Mizzou crew is all here. We're all together.
Wonderful. Great. I hope everybody enjoyed the music in the beginning.
Very nice.
Okay, great. Chris, welcome to the course. Anu Ibrahim, welcome to the course. I hope everybody got the email with the website today and had a chance to do the pre-test, like very quick 10 questions. If you didn't have a chance to do that, you can use the next few minutes to do that. Log to the website and answer the questions, 10 very short questions as a pre-test that we are using for assessment before the course.
This morning, I got it this morning. Did you get it?
And you can access it from your cell phone too. So if you guys are sharing a computer in a conference room, you can just access it from your phone to do the pretest. Also, it's anonymous, so no worries on how you answer it. Just do your best.
I will show the website here. So if you don't have it, you can access through the phone and do the pre-test questions. If anybody just joined, this is a website for the course. If you don't have a chance to answer the pre-test questions, just join there and answer the questions. We will not know who answered correct or wrong, so it's completely anonymous. So feel free to answer the questions in the next couple of minutes until the rest of the crew joins. Let's see, we have 17 joined. We still have some more to join. Also, I will ask you a favor, just keep yourself mute unless you want to ask a question or share some information with us. So we'll keep the recording as clear as we can. The recording will be on the website in the next few days. So just we will get it and we will load it. Zoom link goes away after 45 days. So initially we'll place the Zoom link for the recorded course maybe in the next 2 or 3 days. Then after that, we will try to download the recording and save it to the website so it will stay forever. So it wouldn't go away after the Zoom link goes away. Okay. It is 1 minute after 12, so good afternoon, everybody. So we will start so we can finish in time. Just let me introduce myself. I'm Gohar. I'm Palm Critical Care Sleep, and Dr. Baweja is the co-director of the course. Dr. Baweja, welcome.
Hi, everyone.
Himself. Okay. So I'm running the ultrasound part, and Dr. Baweja is running the echo part. So you will have us today in the didactic. We'll have 2 hours and a half for the ultrasound part, 5 minutes break, then 2 hours and a half for the echo part. I will be presenting the ultrasound part, and the ultrasound part will be didactic maybe half of the time, and the rest of the 2.5 hours will be videos that I will show to you in case anybody is not attending the course. They can get some extra idea about what we are doing in the hands-on part of the course. Fellows are coming tomorrow, so everybody should be here at 8:30. We'll finish around 4:30, and we'll have 1 hour break in the middle. And this hour break in the middle around noon to 1, we'll provide lunch. We'll have some small snacks during the whole day and some soft drinks. Everybody should wear mask when you come, and we will have standardized patients. We have very nice ultrasound and echo machines, and I hope the course will be enjoyable for everybody. So this is a website, as we talked about. And we have the pretest there. If nobody answered the question there, if you can log in and answer them in the next 2 minutes, will be wonderful. We'll give you a couple of minutes for other people to join, and for anybody who did not answer the pretest questions to log into the echo ultrasound course website that Dr. Baweja created. It is in front of you, and we will have the pretest. If you click this link, you can answer 10 quick questions as a pretest evaluation for the course. We'll have the post-test later on at the end of your didactic day.
And once again, if you only have smartphones on you, you can perfectly answer the pretest using a smartphone. You don't need a computer, but you can also do it from a computer if you want to.
Again, please, everybody keep your selves on mute unless you want to ask a question or answer a question. Thank you. We'll start in 2 minutes.
So everybody, please have a good time. Sir, should I come back around 2:30? Would that be good?
Wonderful.
I can join a few minutes early.
See you at 2:30. Wonderful.
So I'll see everyone later, and have a good time. Take care. You are in the hands of an excellent teacher. Please gain maximum from his lecture, and then we'll all see you all tomorrow as well, at least the fellows and the residents in the following weeks. See you soon. Bye.
Thank you. Okay, we will start with the basic ultrasound course in 1 minute. And this will be around 1 hour and 15 minutes didactic. Then we'll show videos for 1 hour and 15 minutes. Okay, it's 5 minutes after, so let's start so we can finish in time. I hope everybody can see my slides moving. If you see my slides fixed to one slide, please let me know. Sometimes this happens. I have no financial disclosure, no conflict of interest. Some disclosure I would like to let you know. We have a Sonosite website. It's available for UMKC residents and fellows. I hope every place can have this website, but it is available, and I had borrowed some slides, and the videos are all from the Sonosite website. And they gave us the confirmation that we can use it for teaching for our residents and fellows and students. I would like also to thank our previous fellows, Dr. Abu Amar and Dr. Balakrishnan, who helped me to get the slides for the Rush exam a few years ago before they left, and they are staff now, and they will come to teach in the resident didactic and the resident hands-on part on the 24th and 25th. This ultrasound echo course is an introductory course, so it's not enough to practice ultrasound and echo. So please, if you see a patient that needs echo, Doppler, or ultrasound, order those. This is something to help you to get an idea that may help you in the assessment of your patient when you get a sick patient or admit a patient. But until you practice more and get more experience, don't rely only on your examination. The objective of this course, by the end of this course, I hope every One will be able to use the ultrasound and echo in assessment of shock and hypotension, assessment for patient with tamponade, assessment for pneumothorax and pleural effusion, assessment of aortic aneurysm and DVT, pulmonary embolism, and also the main goal from the hands-on, we would like you to get an idea how to get a good picture for every organ that you are looking at. And this will be the main goal from the didactic tomorrow, to get a good idea about the normal findings. We'll have 6 standardized patients. We'll have 6 sessions, 3 for ultrasound and 3 for echo. The topics that I will talk about will start first in the first several slides about ultrasound basic introduction. Then we'll talk about the rush exam. And then we'll talk about, as part of the rush exam, the cardiac exam, which we call the pump. Then we'll talk about the tank, which will be part of the rush exam. Also, we'll look at the chest and abdominal exam. Then we'll end with the pipes, which are the aorta and the veins, to look for aneurysm for the aorta and for DVT for the vein. So the 3 ultrasound course sessions that we will have on the hands-on will be session for rush exam. And in this session, you will do everything quickly, just as if you are seeing a patient in shock and you are assessing with the ultrasound. So everyone will have about 20 minutes. We'll have 3 in every session with the teacher. So we'll have 4 in the room. Then we'll have the chest and abdominal exam, which is the tank. And last session will be vascular exam, and we'll look for the aorta for aneurysm, and we'll look for the femoral and popliteal veins for DVT. So we'll start with very basics for the ultrasound. Most of you probably are aware about that. In case anybody doesn't know all these things, we'll talk about echogenicity, transducer frequency, and transducer types. Transducer is the probe. Then we'll talk about the gain and the transducer orientation. Also, we'll talk about the convention. So this is anechoic, and anechoic means you will see it as black, and this is fluid. The top picture is isoechoic. You are barely able to differentiate the lesion from the surrounding, and I will make a circle to show you where is the lesion at. Then the lower picture is hypoechoic, which is less whitish than the rest of the surrounding, versus hyperechoic, which is more whitish compared to the surrounding. Transducer frequency, the higher the frequency, the better the resolution, but will decrease the penetration. So the transducer that has high frequency, like the linear transducer or linear array, will have very high frequency, very good resolution, but very superficial penetration. So you will mainly use it to examine superficial structures. When you decrease the frequency, you will increase the penetration, so you will see deeper structures, but the resolution will be significantly less. And this is like the phased array transducer. So quick quiz, diagnostic ultrasound frequency is, we have 3 options. And the answer is the third option, between 1 and 20 megahertz. 1 hertz is cycle per second. Megahertz is million cycles per second. So for the ultrasound, we use between 1 and 20 megahertz, with between 1 million cycles per second and 20 million cycles per second. Another quiz, which mode should you select when you are imaging close to the surface structures to provide great resolution? And the answer, if your machine is advanced and it has these modes, we need to use the resolution mode or the res mode. Okay, so again, the ultrasound waves move in a different speed and different organs or tissues. So in the solid tissues, like the bone, it moves between a little bit above 4,000 meters per second. In the air, it moves slower, 303 meters per second. In liquid, and soft tissue, it will move between around 1,500 meters per second. The ultrasound uses the 1540 meters per second, which is the liquid soft tissue muscle penetration. That's why you will see these things very well, and you will not be able to see the bone and the air well. And that's why ultrasound does not like the bone, does not like the air, because we are using the speed that goes into fluids and soft tissue. Okay, again, some waves will do different reflections. So if they reflect back, they return to the transducer, and we call that reflection. Sometimes they scatter every direction, multiple directions, and sometimes they are absorbed. And if they are absorbed, they will create some heat, and sometimes they get refraction and they change the direction of the wave. I'll talk a little bit about the three different types of transducers or probes, and we'll talk about the convention. Where is your marker? How to orient your probe. So the three transducers that we will use mostly in the ultrasound will be the phased array transducer, the linear array, sometimes people call it vascular, and the curved, sometimes they call it the convex array. We'll start with the phased array transducer, and the phased array transducer is the transducer that has lowest frequency, very small footprint, so you can put it between the ribs, so you can see that. And this transducer can penetrate very deep, so you can see different structures. And because it penetrates deep and has low frequency, the resolution will be less. We use that mainly for examining the heart, the abdomen, and part of the lung examination. Again, this is the transducer, the phased array. Some people call it the cardiac probe. So lung people are not happy with that, but it is mainly called the phased array. We use it mainly for the heart. That's why some people call it the cardiac probe. It will give you this distance, depth, and also will give you a larger screen than the footprint of the probe. The opposite is the linear, and some people also call it vascular, but the proper name is the linear probe, has highest frequency of the three probes, and also because it is very high frequency, it does not penetrate deep and give you only superficial structures, and is very good for looking at superficial structures with high resolution. If you look here, it gives you exactly the size of the footprint, so it is not showing too much surface area, but it shows exactly where the footprint is. Very common examples to use the linear array probe, vascular assessment. So if you want to place central line or peripheral line, if you want to evaluate DVT, if you want to look for a pleural exam for pneumothorax or interstitial fluid, sometimes you can use it for skin. If you have somebody who's coming with cellulitis and you want to look if there is any collection there that you can drain, there is any foreign body there, you can look at it. Muscles, nerves, thyroid, testicular exam, these are all examples for the use for the linear array, but the most common is to use it for vascular assessment and access. The other probe, the curved array, which is in between the two probes, has a frequency in the middle, has reasonable good penetration. Many times we use it as alternatives to the phased array transducer in some examination. It also has somewhat larger footprint than the convex, than the phased array, and also you can have resolution in the middle between the two. Okay, regarding the convention, we have two conventions, and these two conventions are radiology convention versus cardiology convention. In the radiology convention, in this screen, you see your marker on the screen is to the left of the screen. Your marker on the left of the screen. And when we talk about the left of the screen, your left hand, so this side of the screen. Versus the cardiology, you will have your marker on the screen to the right of the screen, and this is the cardiology convention. The marker of the transducer, different markers for different probes based on the company. Tomorrow for the ultrasound, we'll use the General Electric, and the marker on all our probes will be a line, a raised ridge line. So regarding the orientation, you will get different sections. So if you have a transducer in this direction with the probe, with the marker towards the patient head, you are getting a longitudinal section or what we call sagittal section. So if you look here, this is your aorta, and you are getting the longitudinal section. And your marker here is to the right. You are using the radiology convention, and your head will be towards this side because your marker is towards the head. Your legs will be towards this other side. This was the most difficult slide I made because I had to create this man with the head up and legs down. If you move your transducer and you move your marker towards the right side of the patient or the left side of the patient, you are getting the transverse section. So this transverse section will be as if you are looking towards the patient from the foot to the head. So looking from the foot to the head of the patient. So this will be your picture. This is for the vessel. This is your inferior vena cava. This is your aorta. This is your mesenteric artery. So we are taking section. This will be the right side of the patient hand, and this will be the left side of the patient hand. So example for that. So if you have this transverse section, so this will be the right side of the patient hand. If your marker is towards the right, this is your left side of the patient, similar to the transverse sections in the CT. When you put your probe looking for the right and left upper quadrants, you will put it in the axillary line, mid-axillary on the right, posterior axillary on the left. You are getting section for the patient, what we call coronal section. And this will look like the coronal section in the CAT scan. Everybody looked at CAT scans with the coronal section. So you are getting section for the patient horizontally, and you are getting the coronal section for this patient. Now we'll move to the gain. This is appropriate gain. You can see the vessels are with the blood in them significantly black compared to the soft tissue around them a little bit whiter. This is something a little bit confusing. When you lower the gain, you are making it more black. So lower has L, black has L. So to remember, when you make the gain higher, high has H and white has H. You see the multiple H. So when you increase the gain, higher gain will give you more white picture. So if you want this picture, this is too white for you, the vessel doesn't look black, so you need to lower the gain. If your picture is very black, you may need to increase the gain because lower gain will give you more black picture when you look at it. Now we'll move to the rush exam. And if you're not familiar, what's rush exam? It's abbreviation for rapid ultrasound in shock and hypotension examination. And this rush exam is something that you use to assess patient in shock and hypotension coming to you, especially in the intensive care or in the ED. And again, I would like to thank Dr. Abu Amar and Dr. Balakrishnan helping me to in the starting rush exam PowerPoint that we started a few years ago. Okay, so again, the rush exam can help you to differentiate between the 4 common types of shock. You may have combined shock. This is the 5th type that people always forget about. You can have combination of 2 types of shock. You can identify quickly a reversible etiology. So if you have tension pneumothorax, you can drain this pneumothorax. If you have pericardial effusion with tamponade, so this can be something very quickly to help you to assess. Then you also can guide your resuscitation. Then after you resuscitate, you can assess again to assess the hemodynamic to follow your patient improvement. The rush exam will consist of 3 parts: the pump, which mainly the heart. You look for the left ventricular ejection fraction size, right ventricular size, and any fluid effusion with tamponade. Then the tank, which is the intravascular compartment. You look at your IVC. You look at your thoracic and abdominal compartments to see if there is any leakage of fluid that's causing the problem with hypotension. Then you look at the 3rd part, which is the pipes, and these mainly are the aorta and the femoral popliteal veins. You look for the aorta for any aneurysm. You look for the veins for any deep venous thrombus. Again, these are the 3 parts of the rush exam: the pump, the tank, and the pipes. So for the pump, this is the first thing to assess. You look at your heart and you get parasternal views. You will have long and short axis. You will have the subxiphoid view, and you will have the apical view. These are the 4 views that you look at: parasternal long, parasternal short, subxiphoid, and apical to assess your pump. Some people assess the IVC as part of the pump, but we'll talk about the IVC as part of the tank. This is your tank. So you will assess mainly the A is your IVC in the epigastrium. And then you will look at right upper quadrant, left upper quadrant. We look at the bladder. Then you will look at the lung. Here we have only one side, but you need to look at the lung and pleura in both sides. Then this is the last part, the pipes, and we will look at the aorta. different sites you look at for the aorta: the suprasternal, then you look at the parasternal long, then you look just below the xiphoid process in the abdomen, then you go through the aorta until the umbilicus, or a little bit above the umbilicus until it bifurcates. You can go down a little bit more to look at your iliacs for dissection. Then you look for the vena thrombosis. Mainly you look at the femoral, and you scroll every 1 centimeter down. Then you look at your popliteal vein. Some people use this high mapped abbreviation to remind you what the rush exam steps. This is another graph to show you the steps. It doesn't have the aorta, doesn't have the veins and the DVT. This is a table that shows you how can you use your rush protocol to differentiate between the 4 types of shocks: the hypovolemic, cardiogenic, obstructive, and distributive. You look at the contractility of the heart and the size of the heart. For the obstructive shock, you look if you have any fluid. Do you have tamponade physiology? You have right ventricular strain that may suggest pulmonary embolism. You have thrombus in the heart that may suggest pulmonary embolism. Is your heart hypercontractile in distributive shock? The tank, you will see if your IVC is distended or collapsile, like in patient with hypovolemic shock. Then you look at the pipes. Do you have any aneurysm that may suggest dissection? And also, do you have DVT that may suggest etiology? PE is the cause of your shock. Again, we'll go back to the pump, the heart, and mainly you use the phased array transducer. You will use the cardiology convention, and you look for the 4 views: right parasternal long, right parasternal short, apical fourth chamber, and your subxiphoid. Probe position and orientation, we'll talk about that in details for every view. An important thing, especially in the apical fourth chamber, ask the patient to sleep a little bit on the left side. This will get you a better view. Some people also use the left side rotation for the parasternal. For the subxiphoid, you need the patient on the back. Sometimes, if your patient is in shock and very sick, the subxiphoid may be the only view that you can easily find. Apical and parasternal may be a little bit difficult, but try to get all the 4 views. The pump, again, you will use the phased array transducer, and with the small footprint. This transducer will have the lowest frequency of the 3 transducers and has deep penetration, less resolution. You will use the cardiology convention. So your marker will be to the right side of the screen. You see this green dot. You will use the cardiac exam type. Then you position the probe and orient it based on the view that you are getting, and you will direct your marker towards the certain points to get the view. So when you look at the heart, we are looking at goal-directed echocardiography. So we're not doing full echocardiography in the rush exam. We are looking at goal-directed echocardiography to look for the etiology of hypotension and shock. So you need to look at left ventricular size and function, right ventricular size and function, atrial size, pericardial effusion. If you have effusion, you have tamponade physiology, then IVC size and variability with inspiration, especially in non-intubated persons. Here is the direction. So if you want parasternal long, this is the 3rd, 4th intercostal space, and you direct your probe towards the right shoulder of the patient or towards 10 o'clock. If you rotate your transducer 90 degrees towards the left shoulder of the patient or 1 or 2 o'clock, this will give you the parasternal short. This is the subxiphoid. You see, you hold the probe in a different way because you need the probe as flat as possible. Patient supine, legs bent, and you put your probe at below the xiphoid process, and you direct your marker towards 3 o'clock. The apical fourth chamber, you need to put your patient a little bit to the left side. Your marker is also at 3 o'clock, and you direct your direction of the probe towards the right shoulder so you can get a section of the heart to see the apical fourth chamber view. This is the parasternal long. Patient is supine or a little bit towards the left side. Your marker towards the right shoulder or 10 o'clock. This is what you will see in the parasternal long. You will get more details in that with the cardiology session. So this is what you are looking for, the view that you are looking for. So this will be your right ventricle. Your probe is here. Right ventricle is more anterior. So you'll see the right ventricle first. This is your left ventricle. Left ventricle is connected to the left atrium with the mitral valve. connected to the aorta with the aortic valve. Then here you will see your descending aorta, and this is your pericardium. Exactly the same section that you see here. If I go here, the anatomy, so you look right ventricle, left ventricle, here's your left atrium, mitral valve, aorta, aortic valve. This is the descending aorta, and this is a graph showing the same thing. Be careful, we said you have to be on the cardiology convention with your marker to the right of the screen, so have the proper picture. And the parasternal short axis, instead of your marker towards the right shoulder, you rotate your marker towards the left shoulder towards like 1 o'clock or 2 o'clock. And in this condition, you will have cross-section of your heart. So different views based on how you direct your probe. Some people look at 3 views, some people look at 4 or 5 views. So if your probe is looking upward, so you will see the top things, you will see the pulmonary artery, the aortic valve. Then if you go down, if you direct your probe towards gradually towards the apex, you will see the mitral valve view. Then if more towards the apex, you will see the papillary view, papillary muscle view, and this view is the one that you look at for the ejection fraction of your patient. If you look here, these are the 5 views at the top. So if you are looking upward here, you will see the pulmonary artery. If you go down a little bit, so you are moving the tail towards the patient head slowly, you will get the aortic valve view, then the mitral valve view, and the papillary muscle view, which is important to look at the function of the heart. Then the apex will be the most bottom, and this way your tail or the probe tail is more towards the head, and you are directing towards the apex to see if there is any apical thrombus. These are examples for the 4 views. This is the pulmonary artery and the aortic view. This is the mitral view, and this is the papillary muscle view, and this is the apical view where you look at your thrombus. This is an example for the papillary muscle view, and this is the parasternal short, and you see the papillary muscles here, and you can assess, this is your right ventricle, this is your left ventricle, and you can assess the contraction of the left ventricle. You can also look at the size of the right ventricle compared to the left ventricle in this view. This is the apical 4th chamber view, and again, your patient is on his left side. To see it better, your probe is on the apex. You feel the apex and put your probe at this side, and the marker towards 3 o'clock, and you will direct your probe direction towards the right shoulder, so you can take a cross-section of the heart. And in this condition, your probe will be here. This will be your right ventricle, left ventricle, and the most distal will be the right atrium and the left atrium, or the deepest parts. Sometimes people look for the apical 5 chamber, same apical 4 chamber, but you direct your probe a little bit anterior and superior to find the aorta in the middle. So you'll see the same thing, right ventricle, right atrium, left ventricle, left atrium, and you'll see the aortic valve with the Mercedes sign in the middle of the 4 chambers. Okay, subcostal view, position. Patient is on his back, legs bent a little bit. You put it below the xiphoid, and you direct it a little bit towards the left, markers towards 3 o'clock, and you will go from there. This is what you will see in the parasternal lung. This is your right ventricle, left atrium, aorta, and the valves, and this is your aorta. This is the papillary cross-section and the parasternal short. This is a good contraction. This is an example for reduced contraction and patient with the parasternal lung and apical 4th chamber. You see the left ventricle is somewhat dilated and not contracting well. This is another example, reduced contraction of the left ventricle. Also, the left ventricle here is not contracting well. So based on the wall motion, you can determine which coronary artery that's affected. Then another thing to differentiate between, if you have effusion, is it pericardial effusion or it is pleural effusion? If it is pericardial effusion, the 3 characteristics that tell you that this is pericardial effusion, the fluid will taper towards the aorta, and we call that rat tail. So you see here the fluid is wider. When it goes towards the descending aorta, it is narrowing. So we call that rat tail. Also, you can see fluid between the aorta and the left atrium. So this will tell you that this is pericardial effusion. The fluid will never cross the atrioventricular groove. Versus pleural effusion, you see the pleural effusion here is increasing in width towards the aorta. It will never, you will never see fluid between the aorta, the descending aorta, and the left atrium, and fluid can cross the AV groove because it's in the pleural, not in the pericardium. When you have cardiac tamponade, you look at collapse of any chamber from the effusion, and most likely you'll see collapse of the right chambers, and probably will get more detailed data about that from in the cardiology section. So collapse of the right atrium and the right ventricle are more characteristic. Usually the right atrium, when the tricuspid valve is open, so when the tricuspid valve is open, you expect the right ventricle to fail. When the tricuspid valve is closed, you expect your right atrium to fail. So if you see collapse of the right atrium with the tricuspid valve closed, or collapse of the right ventricle with the tricuspid valve is open, this is what will suggest the tamponade. Again, collapse of the right atrium with closed tricuspid valve, collapse of the right ventricle with open tricuspid valve. When you expect that the blood will be going from the right atrium to the right ventricle, you expect your right ventricle to expand. Also, if you have tamponade, you will have distended IVC with no collapsibility. This is another thing to help you to tell that your patient has some tamponade. Where to measure IVC diameter? If you answer the pre-test question, this is important. IVC diameter should be measured in expiration, because it will collapse in inspiration. To assess the diameter, you need to freeze in expiration. Where to measure it? Two sites, either at its entrance to the right atrium, or 1 to 2 centimeter caudal to the hepatic vein. So see where is the hepatic vein going into the IVC, and go 2 centimeters below that to measure the diameter. This is an example for pulmonary embolism. You see dilated right atrium, dilated right ventricle, even larger than the left ventricle. Then we will see what you call D-shaped septum. So you see here is the D-shaped septum. This is what you call McConnell sign, which is characteristic for pulmonary embolism. You see here the only part that contracts on the right ventricle is near to the apex. The rest of the wall is not contracting. This is what we call McConnell sign. So dilated right atrium, dilated right ventricle, McConnell sign, D-shaped septum, and also you can sometimes see a thrombus will be indication for patient with PE. You can also look at the deep veins, the femoral and the popliteal veins, to see if there is any clots there. This will support your diagnosis of of the pulmonary embolism. Okay, so this is another picture for the McConnell sign. I will leave the TAPSI, which is another thing that will suggest the acuteness of the problem. I'll leave that to the cardiology lecture. Also, this is the excursion for the TAPSI. And this is what we call 60-60 rule. So this rule is not sensitive, but has 94% specificity. Not much people use it, but this is something, if you look at your pulmonary pressure less than 60 millimeter mercury would suggest acuteness. Also, if you have pulmonary exhalation time less than 60 milliseconds would suggest the acuteness of the problem. This is a website, and probably Dr. Bauja will give you better data for that, but this is a free website. If you go there, we'll give you some quizzes to look at the ejection fraction to assess if your ejection fraction is markedly reduced or mildly reduced or moderately reduced or normal. Now we'll move to the second part of the Rush exam, which is the tank. Here, when we look at the tank, we are looking at, first thing, we'll assess the IVC and the longitudinal axis. Then we'll look at right upper quadrant, left upper quadrant, bladder. Then we'll look at the pleura, right and left. So in most of the assessment of the tank, you will use the phased array transducer, and you will use the radiology convention. You will mark to the left of the screen. You will use the abdominal exam type. You will position the probe. Mostly you will have our probe directed towards either the 12 o'clock. Sometimes we'll move it towards the right side of the patient. Some people also use the curved array transducer. They like it better. When you look at the IVC, Be sure you can examine the IBC in either the radiology convention or this is the cardiology convention, your marker towards the right. In this condition, the transducer marker will be towards the head. So if your marker is here, head of patient is here, so your heart is here, your IBC is going to the head. If you use the radiology convention, your marker will be to the left of the screen, and your marker is towards the head, so patient head will be here. So your heart will be to the left of the screen versus to the right of the screen in the cardiology convention. Either are okay, because you may get to see the cardiac convention when you do the cardiac exam. You may see the radiology convention when you are doing the abdominal exam or fast or rush or so. So again, the phased array transducer, some people use the convex array, but usually we use the phased array transducer. Marker towards 12 o'clock, you will have the longitudinal structure. You would like to look to see the hepatic veins going into your IBC. Again, where to measure, either at the junction of the vein with the right atrium or 2 centimeters below the hepatic vein entrance into the IBC. You freeze at expiration to measure. Less than 1.5 will suggest low volume. More than 2.5 will suggest increased volume, and you can see that also in pulmonary embolism or tamponade. You look at collapsibility with inspiration, less than 50% versus more than 50%. This is an example. This is a radiology array. You see your marker to the left of the screen. That's why your heart is here to the left. This is your SVC, the IVC, and this you see here the collapsibility with inspiration versus another vein that's dilated and is not changing with inspiration. This suggests extra volume or tamponade or pulmonary embolism. Quick quiz, true or false? Inferior vena cava size of 2.5 with less than 50% collapse indicates decreased intravascular volume, and definitely this is false. This is the opposite. This will suggest increased intravascular volume. Again, you can measure at the entrance of the IVC to the right atrium or 2 centimeters below the entrance of hepatic veins. Your vein, if it is distended more than 2.5 or 3 centimeters and with no inspiratory variation versus a vein that's collapsing and measures less than 1.5 centimeter, this suggests hypovolemia, this suggests extra volume. Now we'll move to the second part. After we assess the IVC in the tank, we'll look at the abdominal ultrasound. In the abdominal ultrasound, we'll use the phased array. We'll use the radiology convention. The screen marker is to the left of the screen here. We'll use the abdominal exam. What you're looking for, do you have abdominal fluid, ascites? You look at the hepatorenal and splenorenal fissures. Look for your kidneys to see if there is any hydronephrosis. Then you look at bladder. Is your bladder empty or severely distended? Also, sometimes you can look at the urine coming from the ureters to the bladder. This is how the ascites will look like. Everybody is aware about that. These are your intestinal loops. This is your fluid. Here is your probe in this position. This is example for ascites. You probably use that multiple times to mark where is your ascites. You see we are using the radiology convention. Our marker is to the left side. Right kidney and left kidney, you can use, you can do this examination either in the supine position or in the lateral position. The right kidney, you look at the mid-axillary line or subcostal. Your left kidney is a little bit more posterior, so you need to put your probe in the posterior axillary line to find your left kidney. You will, kidneys will look like as if you are putting your hands in, if you are wearing a sweater with pockets, you are putting your hands in the pockets. So this is the direction of your kidney. So to be directing, the lower pole will be more medial than the upper pole. So you need to rotate your transducer a little bit to find the longitudinal structure for the kidney. Then you need to scroll through the kidney from the upper pole to the lower pole to be sure you examine the whole kidney. Then you rotate 90 degrees to look at the short axis of the kidney. Also, then you move your probe up and down to see the kidney from the upper pole to the lower pole. This is example for right upper quadrant. This is your liver. This is your kidney, how it looks like. Then you see some fluid here in the Morrison fissure between the kidney and the liver. Again, This is free fluid between the liver and the kidney in the Morrison pouch. This is the left side, posterior axillary versus mid-axillary in the right side. This is your spleen, this is your diaphragm, this is your kidney, and some fluid in the splenorenal recess. This is how the normal kidney looks like. You see the kidney, the echogenicity, the size. This is the longitudinal section, and the hilum will look a little bit more echogenic than the rest of the kidney. This is the kidney with hydronephrosis. You see a lot of anechoic fluid inside the kidney, thinned parenchyma of the kidney in the longitudinal section. This is the bladder, how it looks like, and in the bladder we'll start with the probe direction towards the right hand of the patient. Then we will move the probe towards the head of the patient to look for your bladder. You can see the urine coming from the ureters on these sides of the bladder. In women, the uterus will be just behind the urinary bladder. Now we'll move to the chest part of the chest exam, and this chest part we will look at three things when we examine the chest during the Rush exam. So we need to assess these three parts. Do we have pneumothorax? Do we have effusion? Then we need to assess the parenchyma, the lung parenchyma. Do we have pulmonary edema? Do we have consolidation? Do we have atelectasis? Okay, quick question. Which transducer is best in viewing sliding lung? So these are the options. And the correct answer is high frequency linear array. So the linear array transducer that you use for the vascular part is the best to look for the sliding side of the lung. For lung examination, we'll use these two probes. We'll use the linear array to look for the superficial part of the lung, the pleura. We'll look for the sliding sign. We'll look at the B lines. For the phased array, we'll look more in the lung parenchyma, and we will look more at the effusion. So we'll use two different types of probes or transducers to examine the lung, the linear array and the phased array. Okay, when we look at the ultrasound and you want to look for pleural effusion, you will need to look at three structures to identify them to see exactly where is your anatomy. You need to see the diaphragm and the organ below it. On the left side will be the spleen, and on the right side will be the liver. You need to have the chest wall, which will be closest to the probe. Then you need to find your lung. Where is your lung? Then the fluid in between. This will be the fluid, and you need to pick a point far from the diaphragm, far from the lung to drain your effusion. To look at the A and B lines and the lung sliding, you need to use the linear probe. If you are looking at the pleural effusion, you need to use the phased array probe, and you probably put it in either at the back or on the axillary line to look at your fluid, and we usually direct the probe direction towards the patient head or 12 o'clock. Okay, so we'll get some slides about the lung sliding and the A lines and the B lines, and we'll see what we have. If we are looking at the lung sliding, your patient will be supine or semi-recumbent. We can start with the linear array, look at the third and fourth space in mid-clavicular line, and we can go up to the second space. And this is where to look for pneumothorax. You can use different sites. You can scroll up and down to find your thing. Very quick quiz. If you are looking for pneumothorax, which area you look at, 1 or 2? Definitely will be area 1, because air is lighter than the lung and will be on the top. So this is where you look at your area, anterior zone. Versus if you're looking for effusion, you look at area 2, which is the lower zone. Again, upper zone, area 1, we will look for pneumothorax. Area 2 will look for the effusion. This is simple anatomy. This is your probe is here. This is your chest wall. These are the two layers of pleura, number 3 and number 6. These vertical lines, what we call Z lines, or we call them B lines or comma tails, so same names. So these are the ribs. You need to find the spot between the ribs to look at your sliding sign. Again, if you are looking for pneumothorax, third, fourth intercostal space, maybe second intercostal space, mid-clavicular line with the linear array probe. If you're looking for effusion, it is in the axillary line, 7th space or below. and you will have your marker towards the 12 o'clock or towards the head in both views. This is what we call A line. So this is the A line, and this is your pleura, and there will be some reflection of the pleura exactly parallel to the pleura horizontal lines, and we call those A lines. And these A lines is at the site of the junction of the tissue and air. So they tell you that the lung has air spaces, and you can see that because of the air inside the lung. Okay, a quick quiz. Absence of A line rules out pneumothorax. True or false? False, because pneumothorax is air, and A lines reflection from the air tissue thing. So you can have A lines in pneumothorax. So A lines does not rule out pneumothorax. You can still have A lines in pneumothorax. When the A lines disappear, if your air inside the lung is replaced by something else, so if your air inside the lung is replaced by tissue, mass, or consolidation, or blood, or any soft tissue inside the lung, in this condition, you will have absence of the A line. So A lines does not rule out pneumothorax. Absence of A line tell you that the air inside the lung is replaced by one of these things: blood, pulmonary edema, infection, contusion, tumor. This is with probably the linear array. So this is your marker here. So you are on the radiology convention. This is your pleura, this is the comet tail, and this is your chest wall. Again, this is the comet tail, the vertical lines, the B lines, the vertical lines. And why do we see this echogenicity? It's hyperechoic, linear lines vertical to the pleura. You can see 1 to 3 or 1 to 4 normally in your view. And these lines are due to the variation in the structure density inside the lung. You have alveoli that have air, you have vessels, you have bronchi. So all these variations will give you this B lines that are perpendicular. When you have increase in the number and width of the B lines, this may suggest something is replacing the air in the lung, like water and pulmonary edema. Sometimes you can see that with consolidation, with pneumonia. This can be diffuse, can be localized to a certain point, but increase in the number and the width of the B lines, this will indicate that your air started to be replaced by something else, like in pulmonary edema or consolidation pneumonia. And increase in this width and density and number, we call them rockets. So we call them lung rockets. It's another name for the B lines when they are more dense and more frequent. All these are pictures for the B lines. Okay. The lung sliding is one of the things that you look at that will tell you probably your two layers of the lung are contacting each other. There is no air in between. And this is another thing to look at when you're looking for pneumothorax. You did thoracentesis, you want to be sure you don't have pneumothorax. You look at your sliding sign. And this is another quiz. Absence of lung sliding and vertical comet tail may indicate pneumothorax. So this is true. So if you don't see sliding line and you don't see the vertical comet tail in an area, this may suggest that you have pneumothorax. Okay. This location for positioning the transducer when looking for lung sliding is at the 3rd and 4th intercostal space and most anterior in the mid-clavicular line. Which transducer is best for viewing the sliding sign? We talked about that, the high-frequency linear array. Another quiz: which kind of transducer in exam you may use during ultrasound examination for pneumothorax? Here, although it's say linear array, but it is not the long exam, it's small parts exam. So that's why we didn't pick this one. The last two, you can use the curved array or phased array or the linear array with the long exam to look for your pneumothorax and sliding sign. Which of the following statements about the lung point is true? And we'll talk about lung point. It was one of the questions in the pretest. Lung point is the area where your two layers of pleura separate from pneumothorax. So one side will have the sliding sign and the other side will not have the sliding sign. And this is the point where we separate the two layers of pleura. So the first two are correct. Lung point is the location where the lung begins to separate from the parietal pleura, and the lung does not slide on one side of the point and slides on the other side of the point. So this is an example for the video. You see this red arrow, this is the point. You see this side here, you see sliding sign. On this side here, you don't see sliding sign. So this is what we call the long point. It is not always visible. Sometimes we cannot find it, but sometimes you can find it. You should look for it. Again, to look for pneumothorax, if you have a normal lung tissue, you will get what we call in the M mode. So you switch to the M mode, and you will look at the chest wall will look similar on either if you have pneumothorax or not, but the lung itself will look like the C, and we call that seashore sign. So this is normal lung. This tells you in the M mode you don't have pneumothorax. If you have pneumothorax, everything will look like the barcode. So even the lung will look like the barcode because there is no motion in the lung. So no motion in the chest wall will give you the barcode. No motion on the lung will give you the barcode. While in normal, the first part will look like barcode, but the second part, the deeper part where your lung is, because you have motion, will look like the C-like. So we call that seashore. This is what you call barcode sign or stratosphere sign. Again, this is a larger picture. This is the normal seashore or beach sign, and this is no motion in the lung because of the pneumothorax. This will give you the barcode or the stratosphere. Again, if you are looking for effusion, you will go to the phased array. You see your marker here to the right, so we are on radiology convention. You will look for, you need to find your diaphragm, you need to find the organ below the diaphragm, you need to find the lung. If you have fluid between the lung and the diaphragm, this is when you think there is effusion. Again, if we are looking for effusion, we are looking at the lower dependent area, area 2. Again, you can do the examination either in the supine position or in the sitting position, like when we start to do the thoracentesis. This is another position you can look for the effusion at. To evaluate for posterior pleural space, you need to move your transducer distally to the 7th intercostal space. This is an example for effusion. You see here your diaphragm. You need, when you look at effusion, you need to find your diaphragm and the organ below it, liver on the right, spleen on the left. You need, this is your chest wall. This is your effusion, the anechoic. Then you need to find your lung. Let me go back to this slide. Here you can see the spine. Normally, you don't see the spine in your ultrasound examination. If you have significant effusion, may show the reflection of the spine. We call that the spine sign. We'll talk a little bit about sinusoid sign, was one of the pretest questions, the jellyfish sign, and the quad sign, and the curtain sign. Curtain sign is a normal finding. So you can see that with inspiration because the lung will go above the liver or the spleen and cover them, and you will see this what you call curtain sign. The sinusoid sign, this is in M mode, in the M mode in patient with effusion. You see this sinusoid sign because the distance between the lung and the chest wall or the parietal pleura will vary with breathing because of the fluid that we have in between. So this is sinusoid sign. This sinusoid view will be in the M mode in a patient with effusion, and was also one of the pretest questions. Jellyfish sign. So this jellyfish sign, or sometimes they call it flapping sign, this will tell you that your lung is collapsed from the effusion. Your lung is very soft and moving very smoothly in the fluid, floating in the fluid. So another thing that may suggest that your fluid is transudate, not exudate, not very strong suggestion, but this is what we call the jellyfish or flapping sign. The quad sign, so this is, you have the effusion, one rib, then this is your parietal pleura, this is your visceral pleura on the lung, and this area here, if it is black, this is suggests effusion. If you change that to the M mode, you will see the sinusoid sign. This is the more complicated effusion. You see the fluid with a lot of septa inside. This is pulmonary edema. You see the B line or the Z lines or rockets or comet tails are increased in number, in width. So this suggests pulmonary edema. Sometimes you can see that with consolidation. If it's loculated, may suggest pneumonia, but very common to see that with patient with pulmonary edema. Pneumonia. So this lung is consolidated or what you call hepatized lung, and this lung looks like the liver. You see this lung looks similar to the liver in density. So consolidation or pneumonia can be bilateral, can be loculated at one side. So if you hear some crackles, especially if you hear bronchial breath sound, you can bring your ultrasound to the area that you hear bronchial breath sound on the lung and look at this lung, you see consolidation there. Again, this is consolidation or pneumonia. This is atelectasis. This is atelectatic lung. This is effusion. This is your diaphragm. And you see here the bone sign or the spine sign. Okay, B lines. You can see increased B line in edema. If you see A lines, this tells you that your lung is dry. You don't have any fluid in the lung. You don't have any consolidation or inflammation. Sometimes in pneumonia, you see the B line or the Z line very thickened like that, and we call them C line. So for consolidation, C line. Again, very quickly, you hear about FAST exam. What's FAST is abbreviation for focused assessment with ultrasound in trauma or sonography in trauma. And this is mainly done in the ED. What they look at? They look at the heart, left parasternal, apical, subcostal, the three views of the heart. Then they look at the right upper quadrant, Morrison pouch. They look at left upper quadrant, the splenorenal, then suprapubic. These are the parts of the FAST exam. There is extended FAST. They add to the FAST two things, lung and pleura and the IBC. This is the extended FAST exam. Again, last thing we will look at is the pipe. The pipe will include the aorta and the DVT in femoral and popliteal vein. Aorta will look at suprasternal notch, left parasternal lung, and upper epigastrium. Then we'll go down slowly until the umbilicus to see the end of the aorta, bifurcation toward the iliac arteries. If you go below the umbilicus, you will look for the iliac arteries. We'll look at femoral vein thrombosis, popliteal vein thrombosis. Vascular exam. This is the vascular session that we will have. One of the three sessions, we'll look for the aorta and the DVT. This is the suprasternal notch. If your marker towards 12 o'clock, you can use the phased array or the curvilinear. This will be your aorta and the branches from the aorta. You can find some dissection there. If you suspect aortic dissection, you do this exam. Patients coming with severe pain, with family history, hypertensive, or hypotensive, then clinical finding. Aorta never above 3 centimeters. So if you have aorta size more than 3 centimeters, you have aneurysm. Iliac arteries are never larger than 1.5 centimeters. So if you have iliac artery more than 1.5 centimeters, you have aneurysm. Some tips to get you, definitely if your patient has not had meal recently, this will be easier to look at the aorta in the abdominal part. If you bend the knees, this will relax the fascia of the abdominal wall and will get better views. If you have bowel gases, you can wiggle your probe a little bit to get the gas away, or tilt the patient a little bit to the left to get the gas away, or angle your view a little bit, and all these things will get the gas away from you. Differentiating the aorta from the IVC, definitely the aorta does not collapse. IVC will collapse. Aorta is more circular or rounded, uniform structure. IVC may have a little bit variable shape. Aorta is a little bit to the left of the midline, IVC towards the right of the midline. And your marker to look for the aorta is to look for the spine periosteum. So the spinous periosteum, and we will find the aorta just more anterior to that structure and a little bit to the left of the midline. Aorta goes from up down, and aorta is more deep in the epigastrium compared to the umbilicus. So in the umbilicus, it's more superficial. So you may, when you are getting the aorta at the epigastrium, you may need more depth. When you are getting the aorta close to the umbilicus, you may need less depth. Aorta size is around 2 centimeters in the upper abdomen. At the umbilicus will taper to 1.5 centimeters. So aorta going from the epigastrium to the umbilicus will be more superficial, close to the umbilicus, and will be smaller in size. This is the anatomy of the vessels. So the first one will be the celiac artery, and we'll talk about the Seagull sign. Then the superior mesenteric. You have the renal arteries here, then inferior mesenteric, then we'll split into the right and left iliac arteries. Okay, so again, this is an important landmark to look at the mesenteric artery. Your left renal vein will pass between the superior mesenteric artery and the aorta. So this is what we call the aorta at the renal level, and you see the superior mesenteric. You can see the renal veins passing between the two arteries, the mesenteric and the aorta. Okay, again, for the aorta, we use the phased array or the curvilinear array probes. Both are okay. We will use the abdominal exam. So your abdominal exam. We'll do two directions of the probe. We'll start with the direction towards the right side. Then we will move the marker towards the head of the patient, or 12 o'clock. Okay, so this is your curvilinear and your marker towards the right side of the patient. So we'll get cross-section of the aorta. You go from the epigastrium down up to the umbilicus. This is what you will look at. So this here is your spine. You see the periosteum, this white line. This is your aorta. This is radiology convention. So your marker here towards the right. And we said the marker is towards the right side of the patient. So this will be the right side of the patient. This is the left side. This is IVC, and this is the aorta. This is your aorta, and above it is the superior mesenteric artery. So find the periosteum, you will find the aorta just anterior to it. Again, this is the same picture, the periosteum, you will find your aorta. This is the superior mesenteric level. This is the Seagull sign. This is the celiac artery coming from the aorta. You see, this is what we call the Seagull sign, and these are the branches, the hepatic and other branches, the splenic and gastric vessels. So Seagull sign is the transverse section of the aorta at the level of the celiac artery. Again, this is one of the views that you need to look for. This is the renal level. So this is your spine, number 4. This is your periosteum of the spine, this hyperechoic line. Then this is your aorta. This is your IVC. And this is your superior mesenteric artery. Number 3 is your renal vein passing between the superior mesenteric artery and the aorta to reach the IVC. Similar, aorta, superior mesenteric artery. This is your spine with the periosteum here, and this is your IVC. Then we go to lower part of the aorta, just above the umbilicus. You will find the aorta, and will split after that to the right and left iliac arteries. Usually the size of the aorta here is smaller, 1.5. It is more superficial. So you may need to decrease the depth to see it a little bit larger. When you cross the umbilicus, you will see the right and left iliac arteries. So the aorta split into the right iliac and left iliac. It is your IVC. Again, you start with the transverse section towards the right hand of the patient. Then you rotate 90 degrees with your marker towards the head of the patient, or 12 o'clock, to get the longitudinal section of the aorta. Here is the longitudinal section of the IVC. Don't mix that with the aorta. And very good marker to look at. It will be going to the right atrium. Also, you see the hepatic veins going through that. So if your probe slides to the right side of the midline, you may see the IVC and think it is the aorta. So be careful about that. So this is the longitudinal section of the aorta. Here you see the first is the celiac artery. Then the second that is parallel to the aorta is your superior mesenteric artery. This is a longitudinal section at the bifurcation. You see the aorta is splitting into the right and left iliac arteries. Be careful when you measure the aorta and the longitudinal direction. You may have what we call the cylinder effect. What's a cylinder effect? If I put my probe on the lateral part of the aorta, and the longitudinal section will look narrower. Versus if you put it properly in the middle, you will have the proper size. That's why it's better to measure the aorta with the transverse section rather than the longitudinal section to avoid the cylinder effect. Aneurysm can be fusiform, can be saccular. This is a risk for rupture based on the size of your aorta. Important when you measure the aortic size, measure from the outer wall to the outer wall, so you can get the proper size. We can measure both the outer wall to outer wall, inner wall to inner wall, but the size of the aorta is the outer wall to outer wall. This is your true diameter. So it's like what here, they are measuring from outer wall to outer wall. Here they are measuring both the outer wall to outer wall and the inner wall to inner wall. This is aorta with aneurysm and thrombus in it. You see here, this is your aorta, and you see this is a thrombus, this is a remaining lumen. This is another larger view, which shows the thrombus inside the aorta. What do you see here? You see this flap? This is flap in the transverse section. This is aneurysm with thrombus inside it. This is the aorta. You see the flap, and this is the true lumen, and this is the false lumen. This is a longitudinal view with the flap. You see that? Now we'll move to the last section, which is how to look for deep venous thrombosis in our patient with suspicious PE or something like that. So what we will look at, we'll look at veins. We need to know the anatomy. In the neck, our vein is lateral to the artery, but in the femoral area, our vein is more medial to the artery. So the medial structure is your vein. What we will use the linear array probe on the venous exam. You need to compress every 1 centimeter. You start at inguinal ligament and compress every 1 centimeter going down to assess for the femoral. If you have DVT, you would have no compressibility, lack of Doppler flow. Sometimes you can see echogenic material inside the vein that may suggest thrombosis. This is here in the left, we try to compress, is not compressible. Here you see visible clot inside the vein. This is another, this is your femoral vein with the great saphenous vein going into it. And you see here clot inside it. This is your femoral artery. So this is the lateral, this is the medial. We like to direct our probe marker towards the right hand of the patient or right side of the patient so we can know the anatomy. So this is lateral and this is the marker towards the right hand. So probably we are assessing the right femoral because this is the more medial, which is the vein with the great saphenous. So this is the more medial structure. So this will be the right femoral vein. Again, for the anatomy, you have actually the venous system should be going from distal to proximal, but let's say here, this is your common femoral. This is the great saphenous, number 2, going towards the common femoral. The femoral vein is more medial to the femoral artery. Then here is your popliteal in the popliteal fossa. In the popliteal fossa, your vein is more posterior. So when you put your probe posterior, your vein will be the one that's closer to the probe. So the vein will be more close to the probe because you will put the probe at the posterior of the leg. So the structure that's closer to the probe is the vein. The structure that's more deep is your artery. Again, the vein is more medial to the artery, and you just look at just below the inguinal canal or inguinal ligament to look for the great saphenous vein going into the common femoral vein. You will follow your vein down every 1 centimeter, compress to find splitting of the vein to the superficial femoral and the deep femoral or profunda. This superficial femoral is misnomination, and there was a study years ago. They asked primary doctors if they will anticoagulate patients with superficial femoral vein thrombosis, and 80% mentioned no. Actually, superficial femoral vein is a deep vein because it has definition of deep vein in anatomy is any vein that's associated with artery with the same name. So superficial femoral vein is a deep vein. That's why some literature started to remove the word superficial. They use common femoral, will split into femoral and deep femoral or profound. When we are doing the rush exam, we'll do the limited DVT screening. So we'll not screen the veins below the popliteal, and we'll not go through the whole things. We'll look at the inguinal ligament. We'll look at the common femoral vein with the great saphenous joining it. Then we'll follow every 1 centimeter until we see the splitting to the femoral vein and the profunda. Then we will move to the popliteal fossa, and we will look at the popliteal fossa. We'll start in the middle, and we'll move a little few centimeters above and few centimeters below to screen all the popliteal vein. This is different from the full DVT examination that will look at even veins below the popliteal. We know that most of the PEs come from DVT in the popliteal or above. That's why in the shock patient, we will look at these two sides, the femoral and the popliteal. Position of the leg, the frog sign. So this is will make it easy. If you put the patient in a little bit reversed Trendelenburg, will make your vein look larger. So this is your artery, this is your vein with the great saphenous vein. Your marker is here towards the right side of the patient. So this is left femoral because this is the lateral, this is the medial. The vein is medial towards the marker. Again, this is your common femoral artery, common femoral vein with the great saphenous going into. Sometimes you can see the valve at the junction of the great saphenous and the common femoral vein. Okay, quick quiz. An acute thrombus within a vessel may appear. Echogenic with posterior shadowing. Acute thrombus cannot be detected. Hypoechoic or anechoic, and the vessel may appear larger due to inflammation. Echogenic with the vessel appearing smaller due to inflammation, and the answer is the third one. Hypoechoic or anechoic, and the vessel may appear larger due to the inflammation. This is the compression. So this is your vein where the red arrow is. I will compress with the red arrow. You'll see complete collapse of the vein. This vein does not have thrombus. So complete collapsibility of the vein rules out any thrombus, even an acute thrombus. So this is a major sign that you will have in acute thrombus. You will not see thrombus inside the vessel. You just will have lack of compressibility of the vein. Again, this is a vein will compress and will not compress. This is a vein that shows a thrombus inside it. So probably this is a little bit older clot in the vein. This is, again, the anatomy. This is the great saphenous vein. This is your common femoral. This is your aorta. Again, for the anatomy, use the Doppler. And the Doppler, it is important because some people think red is artery and blue is vein. It depends on the direction of the flow. So if your flow is going towards the probe versus going away from the probe, and you will have probably when you go into the color thing, you will have on the top here on the screen, you'll have red and blue. So if your blood is going towards the probe, this is artery. This is direction of the blood will be red. If the blood is going away from the probe, will look blue. So it's not artery or vein, it's the direction towards the probe or not. For Doppler, you don't need to be perpendicular. Ultrasound, you need to be perpendicular. So if the blood flowing this way, I may need to put my probe a little bit 30 degrees or so. The more parallel to the vessel, the more you get the color, or if it is sound Doppler, you get more the sound. So if you get your probe perpendicular to the vessel, you will not see any colors, and also you will not hear any sounds. Again, this is your deep vein. This is the common femoral, and this is the femoral vein and the profunda. So these are, this is the artery number 1, and your femoral vein, common femoral vein, already split into the femoral or superficial femoral and the deep or profound. This is larger picture. This is the femoral artery, and the femoral vein already split into superficial femoral or femoral and the deep femoral or the profound. When you look for popliteal vein examination, you can do it in the frog sign, marker a little bit to the lateral, and you will look. Marker direction will not be a major thing in the popliteal because you are looking for superficial structure, which is the vein, and deep structure, which is the artery. So this way can be a way to examine the popliteal, or you can get the patient leg below the bed. This is another way to look for thrombus in the popliteal. You will see your probe is here. The more close to the probe or more posterior is your vein. The deeper structure is your artery. to make it easy, the more superficial structure is the vein, the deeper structure is your artery, popliteal artery. Again, when you look here, marker lateral, superficial structure close to the probe is your vein, deeper structure is your popliteal artery. This is how they look like. So this is the vein, this is the artery. You compress. If your vein compressed completely, then you don't have thrombus. Larger picture. One is the vein, more superficial, closer to the probe. This is the artery. Another picture. This is your popliteal vein, and this is your popliteal artery. When you compress, you see the vein will go away completely. This is the Doppler flow. You can look at the flow inside the vein and inside the artery to confirm. What steps can you take if it is difficult to assess if you are not sure, do we have thrombus or not? So these are the three things that you can do. Never use too much compression, because if you not compressing and compress very hard, you may dislodge the thrombus. You can use the color Doppler to see if there is any flow or not in your vein. You can check the other side to compare. You can wait for a day or so and repeat your study again if you are suspicious, but don't do very hard compression because you may dislodge the thrombus. Now we are done with the didactic part. Any questions about the didactic part? You can unmute yourself. Now I will stop the share with the screen and I will share with you something else. Please let me know if you see this screen that shows the aorta. Everybody, if you can send me something in the chat. You see my screen? Or somebody can unmute himself and tell me that you see the screen. You see it? So hey, you see it. Okay, great. Now I will do some videos for the aorta, then the DVT and the chest and abdomen. I didn't mention anything about the gallbladder in our rush exam, but if we have time at the end of the 2.5 hours, I will show you a video for the gallbladder, because sometimes you have admission with acute cholecystitis and you want to assess the gallbladder, so I'll show you this video. But I will go to the aorta. Videos may take a few seconds to load, and also I will not show you all what we have, but I selected certain views. So I will go to the aorta lesson 2. This is what's available for your MKC residents and fellows. You can go that. There is a pre-test. You answer the pre-test, then you do the lesson, then you will have a post-test at the end of the lesson. So I'll go, lesson 1 usually is the normal anatomy, and lesson 2 is the abnormalities. So I will go to the aorta lesson 2, and I will show you the first video, which will be on slide number 5. I will get to that. Okay, so this is a video, and be sure if you don't hear the sound very well, let me know. Okay, it will take a few seconds to get the sound started.
So what I'd like to do now is walk you through the abdominal aortic exam. We do this exam when we're looking for abdominal aortic aneurysm. We're going to use a phased array transducer. This is a good all-purpose transducer for the emergency department, so you can use this for fast exam or abdominal aortic exam. We're going to start in a transverse view. I'm going to put some gel on the patient from the epigastric area to the level of the umbilicus in a straight line. I'm going to orient the transducer so the marker is to the patient's right, and I'm going to place it straight up and down in the epigastric area. The first thing that you're going to see on the ultrasound image is a round pulsating structure in the middle of the image, and this will be the aorta. Immediately posterior to this round pulsating area will be the shadow of the spine. So we just see the anterior surface of the spine as the white, bright line, and then behind this we see a shadow. That is what we call the spine shadow, and you can use that as your landmark to identify the aorta all the way down the body. So we're going to start in the epigastric area, assessing the size of the aorta. The first landmarks that we want to see to know that we are superior enough above the renal arteries is the SMA. This is going to appear as a smaller anechoic circle just anterior to the aorta. So just be careful you don't mistake this actually for the aorta, because it is possible there could be an aneurysm in the superior mesenteric artery as well. Immediately anterior to this is the pancreas, and then to the right of the patient on the left of the screen, we see the IVC as this hypoechoic structure. So from this point, we're going to move down. We're looking for the left renal vein to cross over as our landmark for the renal level. And we're going to continue moving inferiorly. If you see bowel gas like this, just wiggle the transducer a little bit to try to push it out of the way and work around it. And I'm going to decrease my depth as I move inferior, because the aorta is going to move anterior in the body. So I can decrease my depth to get it into better view. Again, we're dealing with some bowel gas here. I just push it away with the transducer, and here's the aorta pulsating, just sitting anterior to the spine with the IVC to the right. I'm going to continue down to the level of the umbilicus, pushing away the bowel gas. And here I see the aorta divide into right and left iliac arteries. So now we see two round circles instead of one. Once we finish the transverse sweep, we're going to turn the transducer so the orientation marker is facing the patient's head. We'll place it again, starting at the epigastric level. I'm going to increase the depth here a little bit. Find the aorta, and at this point, because I'm in a sagittal view, it should appear as a long black tube moving from the left to the right of the image. We can see here in the image I'm in the very proximal portion of the aorta. We see the liver anterior to the aorta. I move up a little bit, I can see the heart beating just above the diaphragm. So I know I'm at the very proximal level. And I'm going to just start to survey down the aorta. The branch that I'm seeing here, coming at a shallow angle, is the superior mesenteric artery. So I know I'm above the level of the renal arteries when I see that landmark. I'm going to continue down, following it in a longitudinal view. And again, I see the shadow of the spine directly posterior to the aorta. I keep moving down, working around the bowel gas, looking for that long black tube immediately anterior to the spine. And again, I do this all the way down to the level of the umbilicus. And I will see a left iliac artery and a right iliac artery. And again, I can decrease the depth to optimize my image because it is so anterior by the time you get to the level of the umbilicus.
Okay, so this is the first video, and I will show you some slides for abnormal videos. So this will show you as aortic aneurysm. You see how much dilated the aorta. Some videos don't have sound, so I will just describe what we are seeing. This video shows aorta with a thrombus. You see the thrombus there. So this is the lumen, but when you measure the aorta, you measure the whole length. You see that? Don't measure only the lumen. Okay. Here is looking at saccular aneurysm with the color Doppler. You see there is some flow and a different true lumen and false lumen. Next one, which shows aortic dissection. You see the flap inside. Let me make it larger. You see this flap. This is the transverse section showing the flap. This is the longitudinal section showing the flap. Make it larger. You see the flap here inside the aorta. This is the dissection. This is another video to show you the examination. It has a sound, so I'll just increase it and we will let you listen to that.
A curved array transducer with an abdomen exam type is used to perform an ultrasound examination of an aortic aneurysm. Alternatively, a phased array transducer can be used. The patient is placed in a supine position. The transducer is placed transversely in the patient's epigastrium with the orientation marker directed toward the patient's right. The ultrasound examination of the aorta should begin at the diaphragmatic hiatus and continue through the bifurcation of the vessel. The aorta is seen as a hypoechoic, round, pulsatile structure anterior to the bright reflection of the vertebra. The vena cava is a thin-walled, oval structure immediately to the left of the aorta on the screen, which changes in caliber with compression or deep inspiration. The curved, hyperechoic thoracic and lumbar spine can be seen deep to the vascular structures. The celiac trunk should be identified to ensure that the proximal segment of the aorta is visualized. Just caudal to the celiac trunk, the superior mesenteric artery will appear as a small, thick-walled anechoic circular structure just anterior to the aorta. The pancreas is just superficial to the superior mesenteric artery and appears as an oblong hyperechoic structure. The splenic vein can be seen crossing over the superior mesenteric artery along the body of the pancreas. The right renal vein will be seen crossing over the aorta and under the superior mesenteric artery to drain into the inferior vena cava. As the probe is slowly moved caudally, the left renal vein is seen to cross over the aorta. The aorta will gradually become more anterior as the transducer is moved toward the feet. The depth should be adjusted to allow the best visualization. The examination should be continued until the bifurcation of the aorta into the iliac arteries is seen at the umbilical level. Occasionally, bowel gas causes scatter artifact and will reduce visibility in the mid-abdominal region. Continuous gentle pressure or wiping with the probe will move the bowel loops and improve visualization. Alternatively, the patient can be moved into a left lateral decubitus position to reposition the bowel away from the field of view. Note the location of any change in size of the aorta or iliac arteries. At the level of the maximum dilation, freeze the image to measure the aortic diameter from the outside edge to the outside edge in the short axis view. A fusiform aneurysm of the abdominal aorta will measure greater than 3 centimeters in outside diameter. It is important to ensure that you are measuring the true diameter of the aortic aneurysm rather than the hypoechoic false lumen alone. Thrombus within the aorta can appear isoechoic and lead to an erroneously low diameter if not included in your measurement. Next, the transducer is returned to the epigastric area and rotated 90 degrees clockwise with the orientation marker to the patient's head. The liver is seen as a large, hyperechoic structure immediately superficial to the aorta. The celiac trunk can be seen as a thick-walled, hypoechoic structure branching off the aorta anteriorly. The superior mesenteric artery can be seen just below the celiac artery at an acute angle, then coursing parallel to the aorta. The abdominal aorta will have proximal to distal taper. The iliac bifurcation can be identified from the right lateral or coronal approach. The transducer is moved distally to evaluate the walls of the aorta for any change in the shape or size, and should be swept from side to side to identify the maximal size of the aorta. The image is again frozen to repeat the measurement.
Okay, so now we'll move to the slides for the DVT, or the videos for the DVT. It will take a second to load. And I will go to lesson 1 and will show you a video for 5 minutes on slide 18. Let me just get to that slide. Here it is. And I'll maximize that. It has a sound, so I'll let you listen to that for 5 minutes.
So it's actually quite easy to do an ultrasound examination in the ED to determine if a patient has deep vein thrombosis. So this is a well-established practice of ultrasound. We're going to do a modified version of that for the ED exam though. To set up for this examination, you want to tilt the gurney so that you're in a reverse Trendelenburg. So this encourages venous distension of the leg, so it's easier to visualize the veins with ultrasound. We're going to use a linear transducer for this examination, and the views that we do for this exam will just be in a transverse orientation only. So when you're setting up for this examination, make sure the orientation marker again is to the right. For this examination technique, we're going to use a compression technique where we just slightly compress the vein with some downward motion. When you set up the exam on the system, just select the exam key. Then from your menu, select the venous exam type and hit select. When you do this, you're optimizing the system so it's automatically configured for your best resolution of the veins. We're going to use a little bit of ultrasound gel, and we're going to assess 2 areas, the femoral area and the popliteal area. I'm going to start with the femoral area. We're going to place the ultrasound transducer at the inguinal crease in a transverse view. When I do this, immediately below the transducer in the ultrasound image, I'm going to see 2 anechoic strictures. The one that's going to be more medial is the common femoral vein. The one that's more lateral is the common femoral artery. The way I can landmark this is by looking for the junction with the saphenous vein, or the long saphenous vein. And we see this emptying into the anterior aspect of the common femoral vein. And in this image, we actually see the venous valves separating the long saphenous and common femoral veins. So at this point, what I do is I just use my compression technique. So I just push with the transducer down until I see both walls of the vein coapt or touch and meet each other. If I get a complete coapt like this, I know there's nothing between those 2 walls. So there's no venous thrombosis in the vein. So again, just compress down until you see those 2 walls meet completely. You'll see that the artery does not compress and is pulsatile beside the vein. Now that you've identified your landmarks, you want to do a thorough evaluation of that area. So again, placing the transducer at the inguinal crease, we're going to compress the area of the common femoral vein. We want to move a few centimeters proximal to this, so superiorly on the body, and we'll start a compression technique, making sure that those walls collapse completely, and we just work through this area, compressing every centimeter. We see our common femoral vein and saphen junction here, and we can continue compressing just a few centimeters below this. On the ultrasound, we've seen the division to superficial femoral artery and profunda artery, just lateral to the vein. And then we should see the vein divide to femoral vein and profunda vein. Again, compressing all the way down until you see this junction. From here, I'm going to move down to the popliteal region. Just move the system down towards the knee. And we're going to actually go behind the knee, putting the transducer into the popliteal fossa. Once you've identified the popliteal artery and vein, mid-popliteal fossa level, you want to evaluate above and below this area to make sure you evaluate all those areas for deep vein thrombosis. So we're going to start mid-level and just work our way superiorly in the leg to the superior aspect of the popliteal fossa, compressing all the way. We go up a few centimeters, and then we start to move down the leg, compressing into the inferior aspect of the popliteal fossa. Again, making sure that those vein walls actually touch and meet each other. So we know that there's no deep vein thrombosis that's fresh, which would be hypoechoic, would be difficult to see if we did not do this compression technique. Those are the two steps for assessing the leg for deep vein thrombosis. It's just these two evaluation points, but just make sure that you evaluate each area thoroughly and you do your compression technique completely.
Okay, I will move from this video to some videos that they don't have sound to show you abnormalities of the veins. So I'll go to the lesson 2 that shows usually the abnormalities. And I'll start with slide number 2. I will show you here, this is non-compressible vein video. You see they are compressing. This is your vein. This is your artery. This is the great saphenous vein. Your vein is not compressing at all. Next video will show echogenic thrombus inside the vein. This is your artery and this is your vein. You see a thrombus inside the vein. Isoechoic to hyperechoic color, and the vein is not compressing. This tells you that this is relatively older thrombus. We'll move to slide number 4. And this will show another echogenic thrombus. We'll move to slide number 5, and this will show normal compression of the vein. You see the vein is compressing wall to wall. We'll move to slide number 7, and this will show you the Doppler. You see the artery has flow, the vein does not have flow. This is your vein. This is your great saphenous vein. No flow at all inside the vein with the Doppler. We'll move to slide number 8, and this will show you popliteal. This is your popliteal artery. This is your popliteal vein. You don't see any flow with the Doppler, so this is popliteal vein thrombose. Now I will move to the chest or the lung exam. I will move to the second page of this and we'll get to the lung examination. Here's the lung ultrasound, and I will start with lesson 1 that shows the abnormalities, the normal examination. And I will start with slide number 9, 11, 12, and 13 will show you the sliding signs. Okay. You see here the sliding sign. So the 2 layers of the pleura. Let me just make that a little bit larger. For some reason, the slide, when I will show you different slide, when I enlarge it, it gets difficult to load. Okay, so I'll show you slide 11. Also shows the sliding sign. You see the 2 layers are sliding. There's another sliding. This is a rib shadow, so you need to look at the sliding between the two rib shadows. This is a good sliding. Another slide showing the sliding. This is a video that will show you normal lung with good sliding. Then you will change to the M mode to show you the seashore or beach sign. Now they are putting the M mode. They pick the line. You see here, good sliding sign. This is the seashore or the beach sign. This is a chest wall. This is the lung. Because of the movement of the lung, you see it looks like different from the barcode. Next video will show you the A lines. So this is your pleura, and you see here the A lines below it. Now I'll move a little bit to another video for 5 minutes that has a sound. And this video is for 5 minutes, and I will let you listen to this video.
A linear array transducer is used to evaluate lung sliding as an extension of the FAST exam. The orientation marker is positioned in the direction of the patient's head. The transducer is placed in a long axis orientation over the anterior chest wall at the 3rd or 4th intercostal space in the anterior axillary to mid-clavicular line. The ribs are identified in the near field of the image as a bright interface with a posterior shadow. The pleural line is identified as a bright hyperechoic line between the rib shadows. The to and fro sliding movement of the visceral pleural against the parietal pleural with breathing generates the lung sliding sign.
Okay.
A high-frequency linear array transducer with a lung exam type and a low-frequency curved array or phased array transducer with an abdominal setting is used for assessment of the pulmonary system. There are 3 specific areas of pulmonary ultrasound that are reviewed. These are 1. The utility of ultrasound to evaluate for the presence of a pneumothorax. 2. The use of ultrasound to detect and quantify the severity of lung parenchymal disease. And 3. The ability of ultrasound to detect and quantify pleural effusions. Each of these areas will be discussed. The utility of ultrasound to detect the presence of a pneumothorax is useful as this is a commonly known complication of various invasive procedures. To assess for a pneumothorax, one is evaluating for the presence of the lung sliding. This phenomenon relates to the sliding motion that occurs when the visceral and parietal pleura slide across each other during the respiratory cycle. The presence of lung sliding suggests appropriate lung expansion, and thus, absence of lung sliding suggests that the visceral and parietal pleura are not in contact with each. In the case of a pneumothorax, air between the visceral and parietal pleura creates the separation and absence of lung sliding. To evaluate for a pneumothorax, one will use the high-frequency linear transducer, as this will provide the highest degree of image quality of the lung pleura. The linear transducer is placed in the most anterior aspects of the patient in the supine position. Traditionally, working in a cephalad to caudad direction at the midclavicular line at the 2nd or 3rd rib spaces to the anterior axillary line at the base of the thoracic. The indicator should be at the 12 o'clock position throughout the scan. A view of the ribs is key to correctly identify the lung pleura that resides just below. Incorporation of M-mode imaging is useful to detect the presence of lung sliding as well, by evaluating for the presence of motion artifact below the pleural line. Finally, it is important to remember that the presence of lung sliding is reassuring to rule out a pneumothorax in the area of the ultrasound plane. However, the absence of lung sliding can be secondary to a multiple of factors and does not conclusively diagnose the presence of a pneumothorax. The second topic of pulmonary point-of-care ultrasound is the use of ultrasound for the detection and presence of lung parenchymal disease. Given the depth of penetration needed, a low-frequency curved or phased array transducer should be used. The transducer is placed in the second rib space at the mid-clavicular line with the indicator marker directed to the 12 o'clock position to evaluate the lung parenchyma from the anterior to posterior position. Moving in a caudad direction, the transducer should be placed approximately every third rib space along a diagonal trajectory from the mid-clavicular line to the mid-axillary line at the base of the thorax. Recent evidence has shown ultrasound to be exquisitely sensitive in detecting differentiation in aeration of lung tissue. This ability lies on a reverberation artifact that is generated when the ultrasound waves interact with lung parenchyma of different density, created from aerated and non-aerated segments of the lung parenchyma. This reverberation artifact generated produces a hyperechoic vertical line that extends from the lung pleural line through the parenchyma tissue, which should be greater than 8 centimeters. These vertical lines are termed B lines and have been shown to linearly correlate to the severity in lung parenchyma aeration. The greater the number of B lines depicts the greater areas of difference in tissue density in the lung parenchyma captured in the ultrasound plane. Thus, the process to evaluate the entirety of the lung involves placement of the ultrasound transducer in several places along the thoracic. Summation of the number of B lines in each quadrant, along with the total number of B lines, have demonstrated to be effective strategies at quantifying the magnitude of lung airspace disease. The third topic of pulmonary ultrasound is the utility of ultrasound to evaluate for pleural effusion. Ultrasound has been shown to effectively detect and quantify pleural effusion. There are two traditional patient positions for pleural effusion evaluation. 1, sitting position, and 2, supine position. It is important to note that the sitting position will allow the majority of lung tissue to be examined and allow the majority of the dependent area to be scanned in a single ultrasound plane. For either patient position, a low-frequency curved or phased array transducer is needed to allow for the appropriate depth of penetration. The transducer should be placed in the posterior axillary line with the indicator marker directed to the 12 o'clock position. A pleural effusion appears as a hypoechoic structure below the parietal pleural line. One is able to evaluate for complex or loculated pleural effusions by the appearance of hyperechoic structures within the hypoechoic pleural effusion space. One can qualify the amount of pleural effusion by measuring its diameter from the lung pleura base of diaphragm to the lung tissue. It is key to remember the impact of patient position on this assessment. Pleural effusion by measuring its diameter from...
I'll just will want you to see, this is what we call the flapping sign or jellyfish sign. This indicates that your lung is collapsed from the effusion and not from consolidation, and also more likely to have the fluid as transudative rather than exudative. Is not specific, but this is what we call the jellyfish sign or the flapping sign. Okay, now I will show you some abnormalities in the lung with the lesson 2, and we'll start with slide number 2, and we'll show you some slides for, or some videos for pneumothorax, and I will show you also the point sign. So you see here, you don't have any sliding, lung sliding at all. So then when you put the M mode, you see the barcode or stratosphere sign. Same here, there is no sliding, lung sliding at all. And I'll move to slide 8 and 9. This will show you the B lines, the vertical hyperechoic lines, vertical to the pleura. These are the B lines. The more the number, the more the width suggests that you may have some fluid in the lung, and pulmonary edema, or sometimes in consolidation will be way thicker. Another video for the B lines. Then we will move to slide 12 to show you this is lung consolidation. You see, this is the beating heart. This is lung consolidated, or what we call hepatization. Same thing, you see the lung is consolidated, what we call hepatization. This is the jellyfish or flapping sign. This is
a curved
some
array
video for
transducer with
examination.
an abdomen exam type is used to evaluate the chest cavity for a pleural effusion. Alternatively, a phased array transducer with an abdomen exam type may also be used to perform this exam. The examination is performed with the patient in the supine position. The examination may also be performed with the subject in an upright position, leaning slightly forward to allow access to the posterior chest cavity. With the orientation marker directed towards the patient's head, the transducer is placed in a longitudinal scan plane at the 8th or 9th intercostal space in the posterior axillary line. The ribs are seen as curved, hyperechoic structures with dark posterior shadowing underlying the ribs. The pleural line is identified as a thin, hyperechoic line between the rib shadows. The transducer is moved along the posterior axillary line to identify the bright, hyperreflective diaphragm. It is critical to identify the diaphragm so that the intraperineal fluid is not mistaken for fluid in the chest cavity. The scanning depth should be set to evaluate all pertinent anatomy, including the hemithorax, the entire hemidiaphragm, the intra-abdominal solid organ, liver or spleen, and the spine shadow inferior to the diaphragm. Fluid will appear as a dark anechoic area in the dependent area of the chest cavity. The lung may be seen undulating within the fluid during respiration. The sinusoid sign is a term for the characteristic waveform seen on M mode and which represents movement of the lung during inspiration. Another sign of pleural effusion is extension of the spine shadow superior to the diaphragm. Normally, air prevents the visualization of the thoracic spine, but fluid is an acoustic window allowing the ultrasound beam to penetrate deeper. This spine sign is particularly useful for the detection of effusions that are echogenic and may not appear completely black due to exudate or other complex fluid collections. The extent of the pleural effusion can be estimated by moving the probe superiorly and anteriorly to identify the borders of the fluid collection. To guide therapeutic interventions, identify an area of fluid that is sufficiently distant from the diaphragm as well as the lung to avoid injury to these structures.
Okay, next video will be how to assess for pneumothorax.
A
It's 2
phased array
minutes.
transducer with an abdomen or cardiac exam type is used for an ultrasound examination of pneumothorax. Alternatively, a linear array transducer may also be used. This exam may be optimized by turning off image improvement algorithms such as tissue harmonic imaging, THI, and multi-beam imaging, MB, which could impede the identification of useful artifacts. Using a longitudinal plane and with the orientation marker directed towards the patient's head, the transducer is placed on the anterior chest wall at approximately the 3rd or 4th intercostal space between the parasternal and mid-clavicular line. The examination should begin with the asymptomatic chest, using a superior to inferior scanning approach. The ribs are seen as curved, hyperechoic structures with dark posterior shadowing that obscures the underlying tissues. The pleural line is identified as a thin, hyperechoic line between and just deep to the ribs. Reverberation artifacts can be seen as thin, repeating lines at regular intervals that extend through the lung fields and have no clinical significance. In the normal lung, the visceral and parietal pleura can be seen to slide against each other as the patient breathes, causing a shimmering appearance known as the lung sliding sign. Comet tail artifacts, which appear as vertical hyperechoic lines that trail posteriorly from the opposed pleura, may be seen during a normal lung examination. The presence of the lung sliding sign excludes a pneumothorax. In contrast, a pneumothorax results in the collection of air between the visceral and parietal pleura, preventing the ultrasound beam from detecting movement deep to the layer of air. This results in an absence of lung sliding. Again, the pleural line is identified between and deep to the bright hyperechoic ribs. The pleural line is observed for a few respiratory cycles. The absence of lung sliding signifies a pneumothorax. The extent of the pneumothorax can be estimated by moving the transducer across the chest, lateral and posterior to the mid-axillary line to see if any area of lung sliding can be found, which signifies the transition or lung point between the separation of the visceral and parietal pleura of the lung. The presence or absence of lung sliding can be graphically depicted and documented using M-mode ultrasound. An M-mode tracing of normal lung is known as the seashore sign. Closest to the probe, the motionless chest wall produces horizontal lines, while posterior to the pleural line, the movement of the lung produces an irregular granular pattern. In the presence of a pneumothorax, the barcode sign will only show repeating horizontal lines indicating the absence of lung sliding. It is important to note that depending on your patient's position, the highest or most anterior aspect of the chest wall should be identified, considering gravity and where air may be expected to collect within the pleural space.
Okay, the last video will show pulmonary edema. It's 2 minutes.
A phased array transducer with a cardiac or abdomen exam type is used in an ultrasound examination for pulmonary edema. When performing the exam, it is helpful to disable image improvement algorithms such as tissue harmonic imaging, THI, and multi-beam imaging, MB, which could impede the identification of useful artifacts. The transducer is placed in a longitudinal scan plane with the orientation marker directed towards the patient's head on the anterior chest wall at the 3rd or 4th intercostal space between the anterior axillary line and the mid-clavicular line. Examination of the lungs from a lateral or posterior position may increase the sensitivity of this exam. While scanning superior to inferior, the depth should be adjusted to allow for the evaluation of deeper anatomy. The ribs are seen as curved, hyperechoic structures with dark posterior shadowing underlying the ribs. The pleural line is identified as a thin, hyperechoic line between the rib shadows. Numerous ultrasound artifacts are used to evaluate the fluid state of the lung. Z-lines are seen in normal patients and consist of short, broad, ill-defined lines, which begin at the pleural line and disappear within several centimeters. In contrast, B-lines are long, well-defined lines that project posteriorly in a fan-like pattern, move with respiration, and extend posteriorly throughout the lung parenchyma. B-lines are seen in patients with pulmonary edema. Although a few scattered B-lines can occasionally be seen in normal patients, the number of these artifacts correlates with the degree of pulmonary edema.
Okay, so this was the last video for the thoracic exam or lung exam, and now we will move to the abdominal exam. We don't have specific abdominal exam here, so I will look at some slides for the rush exam, and this will be on the 3rd page. Okay, so this is the Rush exam. Will take a few seconds to load. And the Rush exam, I will show you examination of the left upper quadrant, right upper quadrant, and suprapubic videos. Every video is 1.5 minutes, will not be too much. And this is in lesson 2. Just bear with me a little bit because we need to reach to slide 26 on this exam. Okay, so this is the left upper quadrant. And I will show you the video how to examine the left upper quadrant.
A phased array transducer with an abdomen exam type is used to perform the left upper quadrant view in a fast examination to detect free fluid. The orientation marker is directed toward the patient's head. The transducer is placed in a long axis orientation along the left posterior axillary line between the 5th to 7th intercostal spaces. The sonographer's hand will touch the gurney with the proper transducer position. Rotation and oblique positioning of the transducer will help eliminate rib shadows. The patient can be instructed to hold a deep inspiration to move the diaphragm and other structures inferiorly to improve visualization. The spleen is seen as a homogeneous echogenic structure. The kidney can be seen inferior to the spleen. The diaphragm can be seen superiorly as the probe is tilted toward the patient's head and appears as a thin, hyperechoic concave structure. The transducer is swept from an anterior to posterior position to evaluate the entire splenorenal area. Fluid may accumulate in the subphrenic space and splenorenal recess and is seen as a dark hypoechoic to anechoic space between the spleen and diaphragm or kidney. The transducer should then be moved superiorly to visualize the diaphragm and lower pleural space. Free fluid will appear as a triangular anechoic or hypoechoic area above the diaphragm.
Okay, the next video will show the right upper quadrant.
A phased array transducer with an abdomen exam type is used to perform the right upper quadrant view in a fast examination to detect free fluid. Alternatively, a curved array transducer with an abdominal exam type may also be used. The patient is placed in a supine position. To evaluate the right upper quadrant, the transducer is placed in a long axis orientation along the right mid-axillary line between the 7th to 9th intercostal space. The orientation marker should be directed toward the patient's head. Rotation and oblique positioning of the transducer will help eliminate rib shadows. The liver appears as a gray, homogeneous echogenic structure under the ribs. The kidney is seen as an oval structure posterior to the liver. Occasionally, it is helpful to have the patient take a deep breath to move the diaphragm inferiorly to improve visualization. To evaluate the hepatorenal recess for free fluid, sweep the transducer from an anterior to posterior position. Free fluid will appear as an anechoic or hypoechoic area between the kidney and the liver in a space known as Morrison's pouch. The inferior liver tip should be examined by moving the probe inferiorly, as small amounts of fluid may accumulate here first. The transducer should then be moved superiorly to visualize the diaphragm and lower pleural space. Free fluid will appear as a triangular anechoic or hypoechoic area above the diaphragm.
So right upper quadrant, your probe should be in the mid-axilla. Left upper quadrant, your probe should be in the posterior axillary line. And the last video I will show for the abdomen will be for the bladder.
A phased array transducer with an abdomen exam type is used to perform the pelvis view of the FAST exam. Place the transducer in a transverse position with the orientation marker directed toward the patient's right to perform a transverse view of the pelvis for free fluid. The transducer is angled inferiorly to identify the urinary bladder. The fluid-filled bladder will appear as a well-circumscribed collection of anechoic fluid. In females, the uterus will be seen posterior to the bladder. The pelvis is evaluated for free fluid by sweeping the transducer from an inferior to superior position. Fluid will appear hypoechoic or anechoic and will accumulate posterior to the bladder. The transducer should be rotated 90 degrees clockwise with the orientation marker directed toward the patient's head to obtain a longitudinal view. The probe should be swept from right to left to evaluate for free fluid. Enhancement of sound waves by the bladder creates a bright echo posteriorly and may obscure small amounts of free pelvic fluid, so it is important to decrease the gain in this view. Fluid will appear hypoechoic or anechoic and will accumulate posterior to the bladder.
Okay, so just 2 more videos. Every one is 4 minutes for the gallbladder, although it's not part of the rush exam or the quick exam, but sometimes you may need that. And I will go to the gallbladder videos, and I will show you 1 video for the anatomy and 1 video for the acute cholecystitis. To go back to page 2. Here's the gallbladder. And in the gallbladder video, we will see the Mickey Mouse sign. And I'm sure any resident who worked with me, I showed you the Mickey Mouse sign in the CT of the head, which is the midbrain, and the apple sign, which is the pons. But here is the Mickey Mouse sign, will be a different sign, and I will just let you watch that. And also, there are some other signs that they will talk about in the video for the gallbladder to find your anatomy. And I will go to slide 7. This is the video. It is 4 minutes. I will let you listen to that.
A curved array transducer with an abdominal exam type is used to perform an ultrasound examination for cholelithiasis. Alternatively, a phased array transducer may be used. The patient is placed in a supine position, and the transducer is placed longitudinally at the right inferior costal margin in the mid-clavicular line with the orientation marker initially directed toward the patient's head. However, the gallbladder commonly lies in an oblique plane, and the probe may need to be rotated once the gallbladder has been identified. The liver is seen as a homogeneous echogenic structure. Hepatic veins can be seen as small, anechoic structures with hypoechoic walls within the parenchyma of the liver. Portal vein branches may also be seen, but are distinguished by their hyperechoic walls. The transducer is slowly swept along the right upper quadrant. The main portal vein is an easily identified landmark that appears as an anechoic circular structure with hyperechoic walls. The main lobar fissure appears as a thin hyperechoic line that runs between the portal vein and the gallbladder. The common bile duct is located just anterior to the portal vein and will appear as a small anechoic structure with a hyperechoic wall. The common bile duct and hepatic artery may be seen side by side as 2 small circular anechoic structures lying anterior to the portal vein. These 3 structures visualized together comprise the Mickey Mouse sign. Often, the inferior vena cava can be seen posterior to the portal vein. In its long axis, the gallbladder will appear as an anechoic or hypoechoic pear-shaped structure that points towards the portal vein, creating the shape of an exclamation mark. To obtain a true longitudinal view of the gallbladder, the transducer should be rotated until the entire length of the gallbladder is seen. If it is difficult to visualize the gallbladder, a deep inspiration will move the gallbladder below the ribs for easier access. It may also be useful to turn the patient into a left lateral decubitus position so the gallbladder moves away from the ribs. The fundus is the closed end of the gallbladder and is often located inferiorly and superficially, while the gallbladder neck is seen more superiorly and deeper. The transducer should be slowly swept from side to side to evaluate the presence of gallstones. Gallstones will appear as circular, hyperechoic structures with posterior acoustic shadowing. Gallbladder sludge can be seen as echogenic material that will layer out with gravity in the body or neck of the gallbladder. The transducer is then rotated 90 degrees counterclockwise with the orientation marker directed to the patient's right. The transducer is swept inferiorly from the gallbladder neck to the fundus to evaluate the entire gallbladder. The gallbladder wall should be measured in the short axis. After identifying the area of greatest thickness, freeze the image and measure from the outer anterior wall to the inner anterior wall. The normal gallbladder wall should not exceed 3 millimeters. To evaluate the common bile duct for dilation, freeze the image where the common bile duct is seen anterior to the portal vein and measure from the inner wall to the opposite inner wall. The common bile duct diameter should not exceed 6 millimeters.
Okay, and the last video for me, I will show you the gallbladder in acute cholecystitis. I will move to slides 14. Four minutes.
A curved array transducer with an abdominal exam type is used to perform an ultrasound examination for cholecystitis. Alternatively, a phased array transducer may be used. The patient is placed in a supine position and the transducer is placed longitudinally at the right inferior costal margin in the midclavicular line with the orientation marker initially directed toward the patient's head. However, the gallbladder commonly lies in an oblique plane and the probe may need to be rotated once the gallbladder has been identified. The liver is seen as a homogeneous echogenic structure. Hepatic veins can be seen as small anechoic structures with hypoechoic walls within the parenchyma of the liver. Portal vein branches may also be seen, but are distinguished by their hypoechoic walls. The transducer is slowly swept along the right upper quadrant. The main portal vein is an easily identified landmark that appears as an anechoic circular structure with a hyperechoic wall. The main lobar fissure appears as a thin, hyperechoic line that runs between the portal vein and the gallbladder. The common bile duct is located just anterior to the portal vein and will appear as a small anechoic structure with a hyperechoic wall. The common bile duct and hepatic artery may be seen side by side as two small circular anechoic structures lying anterior to the portal vein. These three structures visualized together comprise the Mickey Mouse sign. Often, the inferior vena cava can be seen posterior to the portal vein. To obtain a true longitudinal view of the gallbladder, the transducer should be rotated until the entire length of the gallbladder is seen. In its long axis, the gallbladder will appear as an anechoic or hypoechoic pear-shaped structure that points towards the portal vein, creating the shape of an exclamation mark. If it is difficult to visualize the gallbladder, a deep inspiration will move the gallbladder below the ribs for easier access. It may also be useful to turn the patient into a left lateral decubitus position so the gallbladder moves away from the ribs. The fundus is the closed end of the gallbladder and is often located inferiorly and superficially, while the gallbladder neck is seen more superiorly and deeper. The transducer should be slowly swept from side to side. The transducer is then rotated 90 degrees counterclockwise with the orientation marker directed to the patient's right. The transducer is swept inferiorly from the gallbladder neck to the fundus to evaluate the entire gallbladder. The gallbladder wall should be measured in the short axis. After identifying the area of greatest thickness, freeze the image and measure from the outer anterior wall to the inner anterior wall. The normal gallbladder wall should not exceed 3 millimeters. To evaluate the common bile duct for dilation, freeze the image where the common bile duct is seen anterior to the portal vein and measure from the inner wall to the opposite inner wall. The common bile duct diameter should not exceed 6 millimeters. Patients with acute cholecystitis have a number of characteristic sonographic findings. A sonographic Murphy's sign can be elicited during the ultrasound examination by gentle pressure with the transducer as the gallbladder is visualized. If pain is seen during this portion of the exam, the sign is considered positive. Gallstones or sludge may be seen. However, their absence does not rule out acute cholecystitis. Gallbladder wall thickness greater than 3 millimeters and pericholecystic fluid, which appears as an anechoic stripe around the gallbladder, are also signs of acute cholecystitis.
Okay, this is the last video, and I will stop share. Now we will have 5 minutes for questions, then we'll have 5 minutes for break. Any questions? If you have any questions, please unmute yourself and ask the questions. I hope I can answer. Looks like no questions. Okay, if no questions, we'll take a 5 minutes break. So let's get back together at 2:25. So get ready for Dr. Baweja lecture. So I'll put some music until you come back in 5 minutes. 2:25, please. Thank you. Okay, I will stop here, and Dr. Baweja is ready to start his lecture.
Hi, can everybody hear me?
Yes.
Wonderful.
Would you like to share your screen with us?
Yeah.
We see your screen.
Wonderful. Is everybody back? Are we taking a break? I can't hear you. If you're talking, you're muted.
We can give one more minute.
Yeah, sure.
Thank you.
Hi guys, I think we'll just give it a couple more minutes, start at 2:30 sharp. So if you have something to do or you have friends out there, let them know. 2:30, we'll get going. All right, everyone. Hope most of you are back. We'll get started. Thank you for attending the first half with Dr. Gohar. The second half, we'll try to focus on cardiac echo. So this is a basics of echo didactic. What I really would like people to understand is that this is not a comprehensive license to go ahead and do your own echoes. It certainly doesn't certify you to clinically assess echoes in an official setting, but what it does is gets you started on the path to getting comfortable with looking at echoes, performing bedside echoes. And hopefully what this will do is get your interest going, you learn some more, and then with some more training, you could get to the point where a clinical bedside echo is completely within your realm within months. What we, as Dr. Gohar has already spoken to you about, what we're going to do is follow this by live sessions. The ultrasound part will have 3 live sessions, as will the echo part. So for those of you who are attending tomorrow, the live sessions will be split into 3 parts. One session will show you basic machine handling and getting the cardiac views, what we call knobology and the basics of obtaining the windows. The second will be assessment of chamber sizes and also getting some functional assessment of the chambers. And then the third session would involve some basic valve assessment. Among these sessions, there will be also interspersed evaluation of some cardiac emergencies that you could be hit by in the emergency room or on the floor in the setting of an urgent echo. And we'll cover the relevant aspects of those emergencies alongside these 3 sessions. So, why have echo skills? To me, echo is just the most wonderful tool. It is very inexpensive, pretty much harmless to the patient. There's very little chances, if any, of any adverse events. Extremely portable. Now you have handheld ultrasound machines that you can carry in your coat pocket if you want to, but certainly the machines have gotten smaller too. And you've seen your point of care ultrasound machines that are on wheels are easily movable, and they're widely available. Every hospital now has a bunch of these machines available in the ER, in the critical care settings. Surely the cardiology floor has a whole bunch of them. So they're pretty much everywhere. So if you have such an amazing diagnostic tool in your hands, why wouldn't you put it to use? And if you have the skills, your ability to assess a patient, especially in a critical setting, takes leaps and bounds progress forward. Again, probably the best use of urgent bedside echo is going to be in a critically ill patient. Often volume assessment, cardiogenic shock versus septic shock, concerns for tamponade, concerns for severe valvular pathology. All of these can confound your clinical findings on a physical exam or a history. And obtaining a quick few views at the bedside with an echo machine can hone in on the correct diagnosis and set you off on a path to treating your patient way more efficiently. So I feel this is one of the best bedside tools you can have. And the best part, again, is that it's in your hands. You don't need a tech to come in from anywhere to do it. You carry it on you. So there could, I think this is not a full encompassing scope of where I expect you will use bedside echo, but here are what I think are the most common scenarios in which you'll find bedside echo to be invaluable. As your patients present with shortness of breath and fluid overload-like picture, assessing the systolic function, looking for regional wall motion abnormalities. You're looking at an EKG and you're like, oh, maybe this is a STEMI, maybe this is not. Your regional wall motion abnormality assessment, looking for tamponade and pericardial effusions, looking for volume status, either hypovolemia, hypervolemia, acute cor pulmonale, setting of PE, severe hypoxemia. And then, of course, post-MI patients, if they start to deteriorate on you, you're wondering if there's a complication of acute MI, free-wall rupture, valvular regurg, or septal perfs that you can assess at the bedside. In the ER, patients coming in with chest trauma, there's always a concern if the chest trauma involved any cardiac injury. And then assessment of shock, where the picture isn't clear whether you're dealing with cardiogenic shock, septic shock, or you have a mixed shock picture. That's where I expect this will be an invaluable tool and get you out of trouble. So I know Dr. Gohar has gone over with you in a little more detail about the physics of ultrasound and echo. For an echocardiogram, the transducer we use is a range 3.5 to 5 megahertz processor. In today's day, this is a phased array piezocrystal in the transducer. What this means is, there's a multiple ultrasound generating piezocrystals within the little transducer that you hold in your hand, and then there's receiving sensors for those ultrasound waves that bounce off tissue, cardiac tissue, chest tissue, and come back at the probe. A variety of modes are available to assess the cardiac function and tissue. Some of these modes are not in vogue anymore, and I'll be honest with you, some of these were out of vogue before I even trained, and hence you may never see them. But these are the historical modes that you should be familiar existed, because this is how we progressed to where we are today. So, just to go over the modes, the A mode, or the amplitude mode, hardly ever used in practice these days, is a graphical display of deflection against time as those ultrasound waves hit back at your probe. This was the very first ultrasound that was done, was in A mode. And I'll show you a picture in a second and you'll realize, it's amazing how people made sense of that, because it won't make much sense to us in today's world. The B mode 2 is, the B mode is where you hit the 2D button on your echo machine and you start to see pictures of structures that look like the real heart and valves and structures around it. So that's the mode that you use, the most common. Realize that this is a real-time image. In good modern machines, you can get frame rates in excess of 30 per second, which means that you can get a smooth movie-like image. And the reflection of the ultrasounds to the probe are congruent with the density of the tissue they're hitting, and hence you get proportional brightness. So if you hit calcium, you get very bright reflections, medium for tissue, and hardly anything for blood. And then when you don't have good blood flow and you get roulet formation, then you get in between gradation of gray. So its brightness is very congruent to the density of the tissue it hits. M mode is still in use. M mode is it's not trying to generate a 2D picture for you, but it's like a cross section with a moving time integral. And I will show you some examples that will help you understand this in a second. But of course, the most commonly used mode is going to be the 2D echo. The two-dimensional look, which looks like the heart structure. This is what you're used to seeing. This is what correlates with anatomy that you have learned all through your life. And this is what makes sense to us today. Here, the ultrasound is transmitted along several scan lines. It can be about 100 scan lines over a wide arc, kind of arches away from the probe. And this happens more than 30 times a second, so as to generate a movie-like picture. The combination of the reflected ultrasound signal is then picked up by the sensors in the same probe and digitally expanded to a picture on the screen. And because the ultrasound's originating from a probe that's about yay big, you're going to see a cone of ultrasound diverge from that, and that's what you're picking back up to. So you're going to see a cone on your image. That's what it'll look like. And then there are certain other things we will do. Pulse waves are just ultrasound waves that are looking for local velocity. You can point it at any structure or fluid in the heart tissue. And what it's just going to do is it's going to tell you how good the flow is and in what direction the flow is, what kind of velocities that flow is achieving. Or if you point it at a tissue, what kind of velocity that tissue is achieving in its translation through the heartbeat. And pulse wave is very useful in trying to assess, fluid flow in specific areas of the heart, and we'll talk a lot more about that. And then the most dramatic looking picture comes from color flow mapping, is when we throw color on superimposed on ultrasound picture, which may be an M mode picture or a 2D picture, and you start to see the flow of blood in the cavities across the valves. And what the ultrasound machine does, and this is just an electronic configuration, is that if the blood is flowing towards the probe, it colors it red. If it's flowing away from the probe, it colors it blue. And if it is turbulent flow, it'll be a mix of blue and red. And if it's not flowing towards the probe or away from the probe, you really won't get much color. So this can help you assess the direction of blood flow or the turbulence of blood flow. And it really helps understanding the flow across valves or through abnormal openings such as an ASD or a VSD or an aneurysmal opening. And here's that little picture I was promising you. This is what the A mode looked like. As you can see, this is just blips on a line. And at one time, this is kind of what helped people understand what an echo would show. And the B mode is now expanded into our 2D echo, and it's a cone of pictures. And the M mode is here on the right, showing you a slice in a continuous time interval. So a little more about Doppler echo, because that's going to be a mode we're going to use very often in an interrogation of the heart. So it's a method of detecting the direction and the velocity of moving blood within the heart, and that's the whole point, right? Everything we are concerned about is how is the blood moving through the heart. So pulsed wave is good for low velocity flow, such as a mitral valve flow. On the other hand, a continuous wave is more useful for high velocity flow, such as in aortic stenosis. And then we talked about the color flow that helps us understand not only that there is flow, but in what direction it is and how turbulent it is and what is the shape of the jet, etc. So if you look at these two pictures on the right, the picture on the top is showing you a continuous wave, and you can see how the entire flow is charted like a graph. And if you were to look at the peak point of this flow, that is the peak velocity that this flow achieves. And if you were to look at the area under the curve, that would be the mean flow across the valve. Here is a color representation where a patient appears to have both significant tricuspid and mitral regurgitation. And you can see how these jets coming back into the atria, across the valves, and how turbulent they are. This is all mixed up. The blues and reds are so mixed up. So this is very turbulent flow, as you will see in significant regurgitant flows. So once again, these are the kind of exam modes that you will use, and that their values. 2D imaging will be assessment by anatomical assessment and valvular movement, and then regional wall motion abnormalities. M mode will help you measure motion over time. These are very invaluable for distance and depth measurements, and I will show you with some examples coming forth. Then continuous wave and pulse wave are more for hemodynamic assessment across valves, looking at stenosis and pressure gradients. And then color flow is a visual representation of blood flow and can yield a lot of quick hemodynamically useful data that is very visually easy to understand. So there are various types of transducers. Again, I think Dr. Gohar has covered some of them. These include linear, curvilinear, or sector arrangements. And these probes come with different penetration, different frequencies, and produce different image details. But for cardiac assessment, adult cardiac assessment, we end up using one probe most of the times. And this is a curvilinear probe with a small footprint. And usually the number S4 is imprinted on these probes. So when you have a machine with multiple probes and you're trying to decide what you want to grab for your cardiac assessment, this is the probe you want to grab. I know this is kind of basic, and you'll wonder why I'm telling you all this. I think in our excitement in new procedures, we forget some basic etiquettes around a patient. I was doing an echo TEE with a trainee not too long ago, and the patient just got in, and the fellow was of course very excited to look at the TEE probe. I think it was his first few TEs. And he pulled the TE probe out and started moving it around right in front of a very awake patient. The awake patient looked at a TE probe and, was very intimidated and eventually refused the procedure. So always remember, we want to approach the patient with good etiquette in a good, comfortable environment, take permission, undress them, cover them in areas that you don't need. And ergonomics play a big role in getting any test successfully done. If you don't have good access to the patient, or the patient is not comfortable, you're not going to be able to complete your test in an easy manner. So make sure you make the patient as comfortable as possible, get them in the right position, supine, a little bit of left lateral turn. Make sure you have adequate gel. Gel is what makes the ultrasound smoothly transit from the probe where it's generated to the tissue. That little bit of air and air gap in between is eliminated by the use of gel. So appropriate ultrasonic gel should be available at all times. Most places will have gel warmers so that you don't apply cold gel on your patient and freak them out. But despite doing all this, getting the right position and getting the appropriate gel and everything, you still may not be able to get the most optimal images because there are limitations. It is a surface test, and anything that comes between the probe and the heart is going to limit your quality of image. Very obese patients, patients with obstructive airway disease, with hyperinflated chests, or existent chest wall deformities, patients who can't lay appropriately on their side, all kinds of arthritis or fractures or injuries may prevent them from positioning the way you would like it. Presence of a lot of edema, that these can all be detractors in getting you the perfect images that you're seeking. So be sensitive to getting the patient appropriately set up, but then also know that this is a surface test and there will be limitations. Now, as you grab your probe, you will notice along one edge, there will be an index mark. This index mark could be a line or a dot, but one edge is going to have that and the other won't. Now, this index mark is very useful for you to orient the probe right, so that the pictures that show up on the screen always appear in a standard format. There is an ASE, or American Society of Echo, convention on how to hold the probe so that the images always look the same and are very comparable. If any of you have had experience at the Mayo Clinic, then you will realize that they just do the opposite of this. They don't follow the ASE convention and have the opposite method. So if you ever see pictures from a Mayo website, you'll see them flipped around. But that's Mayo. They get to do what they want to do. For the rest of the world, we try to follow the ASE convention. And what I'm going to show you today, it's going to be how to hold the probe for each view in the ASE convention. So the idea is that if you hold the probe this way for every view, and everybody does, then the picture on the screen, the structures are laid out just as you want them. For example, in an apical 4-chamber view, the index mark should be pointed towards the left of the patient or the left shoulder, and then you should and that will cause always the left ventricle to show up on the right side, and so on. We'll keep talking about this. As you apply the probe to the chest wall, realize that there's a lot of things in between. There's soft tissue, there's the ribs that are in between you obtaining that image and the heart tissue. So you will often need to move your probe around and change your orientation of your probe to get the ideal picture. Every patient is a little different. The heart sits in the chest cavity a little different for everyone. How tall they are, how wide they are, et cetera, makes a lot of difference. Diaphragmatic issues can cause the heart to be differently oriented. And then, of course, I'm not even discussing dextrocardia. Even in normal configuration, the heart can have a very different orientation in every patient. So there are some well-defined movements of the probe that you should know and should not be afraid to use to your benefit. Translation of the probe is where you move the probe across the skin from up, down, left, right. Angulation is referred when you tilt the probe to get a more cephalad or a more caudal look. The rotation is when you turn the probe on the long axis of the probe, and a tilt is like a heel-toe movement. The probe is longer in one dimension, so that heel-to-toe movement is known as a tilt. And we'll talk about these as we get to the views, so it's good to get this lingo out of the way. when you do your cardiac exam, this is the preferred orientation, that you sit between the patient and the echo machine with the patient to your left. You learn to scan using your left hand. That way, your right hand is available to handle the machine and change the settings and record and go from 2D to M mode to Dopplers to color flow, etc. So this is the ideal positioning of your patient in respect to you and the machine that I would expect all of you get used to. There are three main areas where we will be finding windows to look into the heart. These are the three main areas, and we'll talk about some other ones too, but the three main ones are here. They are the parasternal views, where the probe is positioned, as the word goes, in the left parasternal area. Then apical views, where the probe is below the breast, kind of pointing upwards, looking at the heart from where the apex of the heart would be. And then subcostal views, looking from below the xiphoid, looking up from under the breastbone. So in the parasternal areas, we can have some variations. We can have what's called a parasternal long axis and a parasternal short axis, and I will describe them to you shortly. Also, in the apical area, we'll have two variations, actually three variations. There's a 2-chamber, 4-chamber, and a 5-chamber. Then there is the subcostal view, where you do see all 4 chambers, and a variation of that subcostal view will help you look at the inferior vena cava. And then there is one other view, the suprasternal notch view, where you're kind of looking down upon the heart. It's an excellent view to look at the arch, the aortic arch and its branches. So these will be the main views, and let's go over them one by one, look at the nuances, look at what you expect to see in each one of those views. Again, as you look at these images, these are the kind of things I'm hoping you can assess: volume status, myocardial dysfunction, effusion, findings of PE, and we'll kind of intersperse them as we talk about these views, looking for complications of MI, VSD, PAT muscle rupture, looking for valve dysfunction. And one of the most common findings on a 2D echo, believe it or not, is finding a pleural effusion. So yeah, you can find pleural effusions, and mostly will on 2D echo. And the clinical setting, of course, is really important in which you're going to do the test. So post-cardiac surgery, post-cath, post-trauma, in a patient with renal failure or infection, you have hypotension, tachycardia, you're looking for a pericardial effusion, so look for those findings. In a patient with PE or an RV infarct or pulmonary hypertension, look for dilated RA and RV. Whereas in ischemic heart disease or dilated cardiomyopathy or volume issues in terms of volume overload or aortic valve pathologies, look for dilated left-sided chambers. So these could all be the first focus of your attention, depending on the pretest condition that you're evaluating. And then, of course, LV hypertrophy will be a very common thing you'll find. And then when you see LV hypertrophy, arterial hypertension will probably be the most common cause for it, but you start looking for other issues such as aortic stenosis or LV outflow obstruction in the setting of a hypertrophic cardiomyopathy, or myocardial disease, deposit disease. So these are some of the things that should jog your thinking process as you're looking at things. So let's start with the subcostal view, the subcostal four-chamber view. Here, the transducer is positioned, as we said, under the xiphi sternum. The marker dot, this is the dot on the edge of the probe that we talked about, points to the left shoulder of the patient. The patient lies supine with head slightly low, so no pillow, feet on the bed, and you get the knees slightly elevated or bent, and this relaxes the abdominal muscles and allows you to get a little deeper in the epigastric region so that you're able to get under the ribs and get a good picture looking at the heart from below. So the abdominal muscles have to be relaxed, and the best pictures, of course, will be obtained when your patient takes a breath in, and you'll get a better view of the heart. Here, the structures that you will very well evaluate are the intraatrial septum. This is a wonderful view to look for pericardial effusion, especially if you're planning to tap this effusion, because this is exactly where your needle will go into most of the times, and also look at the descending abdominal aorta. So here I have a picture for you of how your patient will be positioned and how your probe will be positioned. And you can see the knees are slightly bent, and you can see the probe. You do have to exert a little pressure here because you really want to get under the rib cage. So you do have to push in a little at the epigastrium to get this view correct. And the marker is always going to point to the 3 o'clock or the left shoulder position, however you want to remember it. Sometimes people with epigastric pain issues, etc., may find this view uncomfortable, and you may not be able to get it if they are hurting with your pressure on the epigastrium. Other times, people who are really obese, that'll be hard to do because you won't be able to get below the rib easily if the belly is large. Now, as you look up from this view, here is the cone of the ultrasound. This is kind of what you're looking at. The first structure that you're gonna see will be the right ventricle, and you'll see the left ventricle and the 2 atria behind over there. So here's the anatomical picture of how this ultrasound will appear to the probe sitting here at the point, and here is the corresponding ultrasound picture: the right ventricle, right atrium, left ventricle, left atrium, with the corresponding valves in between. So you can see how good this is to evaluate the entire septum. If there's any effusion, you're going to see it right here in front of the right ventricle. And, behind here, you'll be able to assess the descending aorta as well. So you can see how this view is going to be really helpful in certain scenarios. Effusion, one of them; assessing the septum would be another. Another image is to show you a real world picture of how the subcostal view would look. And as you can appreciate, the first structure you're going to hit is the RV right here. So realize that this will be a great view to assess the RV free wall in the setting of tamponade as well, because in tamponade, you're expecting to see some diastolic collapse of this RV free wall. And you can see how well you can see the RV free wall in this picture, and that would be a good view to make that assessment. Let's now talk about the suprasternal view. This is looking from the suprasternal notch down. Here, the marker dot is pointed towards the left jaw. Again, kind of like in a 3 o'clock position if you were looking at it from down there, but because you're looking at it up there, it's up to you whether you want to call it 3 o'clock or 9 o'clock with the left jaw. And the subject is lying supine with the neck hyperextended, of course, to allow you access to that suprasternal notch. And the head is rotated slightly leftwards. The position of the arms and legs here don't have much bearing, but this is an excellent view to look at the arch of the aorta. So if you're suspecting aortic dissection in the ascending and arch, this would be a wonderful view to make that diagnosis very quickly. You could also see some of the major branch vessels in this view, and I have put forth on this slide the image that you would see from an ultrasound probe and the corresponding anatomy that you're looking at in the suprasternal notch view. So the arch, as you can see, is very, very nicely laid out. Any type A dissections would hopefully be easy diagnosis on this view. Now let's get to the mainstay views. These are our parasternal views. As I had mentioned, there are two types of parasternal views. One is the long axis, and as the name defines, it is looking at the heart in a long axis. And you turn the probe to then look at the heart in short axis, and we'll talk about that in a second. In the long axis view, the index marker of the transducer is pointing to the right shoulder. So you know your heart is aligned, going to the apex going to your left. So when you have the probe pointed to your right shoulder, or the patient's right shoulder, that's in the long axis of the heart, and that's how the long axis view will be produced. Again, the probe is on the left sternal edge, the dot pointed to the right shoulder, and the patient should be slightly leaning towards the left side, so their heart moves forward in the chest cavity some and towards the bony cage, giving you a more clear picture. Kind of an example of how this view would be obtained in real life. And this is kind of, so these are sketch drawings. And the reason I thought these sketch drawings were really useful is because they allowed you to not get puzzled by all the other things that you're going to see on an echo, and just focus on what the important structures are. And once we look at the sketch drawings, then we'll go to looking at what an echo image will look like. So here in the parasternal long, closest to the probe is going to be the right ventricle on top, pericardium, of course. Then the interventricular septum, the left ventricle below that. Left ventricle, always easy to identify because it is the thickest, most muscular chamber most of the times. And then across the valve from the left ventricle in an inflow pattern is the mitral valve in the left atrium. The outflow pattern is the aortic valve and the aorta. And this is kind of what you're going to see in the parasternal long, and you may see the descending aorta behind all your cardiac structures right here. Okay, so this is just a schematic of what I hope you will see. Again, this is the probe position, parasternal, dot towards the right shoulder. This is how that schematic will translate into a real echo image, RV, LVOT, AV, LV, mitral valve. You may see the descending aorta behind here. And this is just showing you how the anatomic orientation of the heart is going to be when you approach this view on echo. Now, think about it. Here's the probe pointed to the patient's right shoulder and aligned along the axis of the heart. Now, if you were to just spin the probe along its long axis to point to the other shoulder, you're now looking at the heart, cutting it in short axis, right? So really, once you've got the long axis view sorted out and identified all these structures and looked at the appropriate function that you would like, then you turn the probe clockwise, 90 degrees, so that now the marker is pointing to the left shoulder of the patient. And by tilting and shifting along the line of the long axis, you can actually get a series of views. And let me explain what that means. So first, what you're doing, you're about in the second to fourth intercostal space on the left, on intercostal space on the left sternal edge. You dot, you've gone now pointing towards the left shoulder. And now what you're going to do is you're going to tilt and translate the probe cephalad caudal a little bit, and you're going to obtain sections of the heart in its short axis at different levels. And this is what I mean. So when you point all the way caudal, you're going to look at the apex of the heart. You point a little more mid, you start to see the mid cavity of the left ventricle. And how you can appreciate that is you will see the papillary muscles. As you start to point a little more cranial, then you will cut the mitral valve in short axis. And it's a very easy to appreciate valve because it just looks like a fish mouth opening and closing. And then as you translate and tilt a little more north towards the cephalad direction, you end up with the short axis of the aortic valve, the inverted Mercedes-Benz sign, so unmistakable, right? So this is kind of what's happening as you're tilting your probe along the heart short axis. And you're going from the apex to the mid cavity, to the mitral valve, to the aortic valve. And as you can see, this is not just a translational movement, it is also a little tilting movement. So you're tilting and translating for each view ever so slightly to get to these various views. So let's kind of go over them and the structures that you will appreciate on each one of them. In the parasternal long, let's start at the apical view. You may or may not see much of the RV in the apical view, but essentially, when you see a small cavity of the left ventricle without prominent papillary muscles, you know you're kind of at the apex. A very good view to assess for a few things. Number one, if there is a LAD involvement in acute MI, looking at the apex is really going to be useful. Number two, if you have any aneurysm formations there, you may be able to see them here. Not an ideal view usually to see apical clot, but I've seen people being able to appreciate that on this view too. Then as you tilt a little up, then you start to see the papillary muscles in view, and now you know you're in the mid-cavity view of the left ventricle. In the mid-cavity view of the left ventricle, you are also now able to see the right ventricle alongside the left ventricle. And the right ventricle is going to be closer to the probe, so it'll be on top. The left ventricle will be a little lower, okay? Then tilt up slightly forward, and instead of the papillary muscles, you'll see the fish mouth appearance of the mitral valve. The leaflet that is closer to the probe is the anterior mitral valve leaflet, and the one that's away from the probe is the posterior mitral valve leaflet. Now tilt up a little more, and then you get this remarkable view where you see a lot of different things. You see the aortic valve, no doubt, the inverted Mercedes-Benz. But then what you're seeing closest to the probe is the right ventricle. And you're able to appreciate the tricuspid valve on the left of the image here with the right atrium below that. The left atrium is also seen adjacent to that. And you can see this is a complete circuit that you see here. Right atrium, tricuspid valve, RV, into the pulmonic valve, down the PA, and with a good assessment, you can actually see some bifurcation of the PA. So a great tool to assess this entire circuit in one view right here on the right side circuit. Okay. So again, a schematic of this view, because it's a little complex, so I wanted to put it up there, that you're going to see the right atrium, tricuspid, RV, pulmonic valve. You're going to see the PA with hopefully branching as well. Left atrium sits here at the bottom with the aortic valve right in the middle. This is a sonographic view now of the same structures that look perfect on a sketch, but this is kind of how it'll look when you see it on a sonographic image. Now, as you see this image, know that the aortic valve has three cusps. They're called the right coronary, left coronary, and non-coronary cusps. And in this view, the arrangement is that towards the RV is the right coronary cusp, and then you go clockwise, it's the left coronary and the non-coronary cusp. Okay. Often you can actually see the left coronary take off right here if the picture is clear enough. Also, this is a view where sometimes on a 2D echo, you might get a very clear look at the left atrial appendage that goes right here along the aortic valve towards the between the pulmonary arteries. So sometimes this may be the view where the left atrial appendage is very clearly visible, and you may make a diagnosis of left atrial clot if seen on this picture. This is the mitral valve view we talked about. You'll see some of the RV there. Then you move lower. Here's a moving picture of the same. As you can see, the fish mouth mitral valve, the anterior mitral valve leaflet, posterior mitral valve leaflet. This is the RV, and you're seeing part of the tricuspid valve in that picture. Continue a little more south. This is your right ventricle with the papillary muscles in the left ventricle here. So know that, contrary to what you might think, that the anterior wall is going to be on the top, the definition here is going to be based on the orientation of the RV. The RV is where the septum is. So if you turn your entire imagination, you'll see this is the septum, this is the anterior wall, this is the lateral wall of the left ventricle, and this is the inferior wall of the left ventricle. So always find your septum in relation to the RV, and then you know where the anterior, lateral, and inferior wall orientations are. If you're trying to call hyperkinesis and acute MI, this is kind of what you're hoping to look for. Again, this is kind of how it would look like on a real 2D image. You can appreciate those thick papillary muscles right here. This tells you you are in mid-cavity in the left ventricle. So this is your parasternal long and short axis. Now let's go on to talk about apical views. And when you look at the heart from the apex, this is kind of easy to figure where to place your probe if you just palpate the apex, and you can place your transducer right there. For the 4-chamber view, you're hoping to find all the 4 chambers. The index marker is located at the 3 o'clock position, which is your left shoulder. To look at the 2-chamber view, you have to turn the probe 45 degrees anti-clockwise, okay? So you're counterclock turning the probe about 45 degrees so that you're cutting the heart back to front instead of side to side, which is where the 4-chamber cut is going to be. And in a second, I'll show you. In the 4-chamber view, you can also tilt or fan the transducer a little towards the surface of the anterior surface of the patient, and then you can that way open up the 5th chamber to reach the 5-chamber view. And this is the LVOT, and you'll be able to see the aortic valve that way too. So let's go look at all these views. Again, initially for your 4-chamber view, you placed your probe here below the breast at the apical, where you feel the apical impulse, and the marker is at 3 o'clock position. And here you will see on the screen in convention, if you've held the marker right, the left ventricle on the right side, right ventricle on the other side, you'll see both valves, you'll see both atria. Great view to assess the valves as well for regurgitation and stenosis. But also realize here, you're appreciating two walls of the left ventricle very clearly. Across the RV, this is the septum. And across the septum, this is the lateral wall. So you're appreciating the septum and the lateral wall in this view. And as you turn that probe 45 degrees counterclockwise, you'll go from this 4-chamber view that you're seeing all the 4 chambers to eliminating the right-sided chambers from your view. And as you turn the probe 45 degrees, this 4-chamber view will turn into a 2-chamber view where you'll only see the left ventricle and the left atrium. Now, the difference here is that because this is looking at the left ventricle back to front, the walls that you're seeing are no longer the septum and the lateral wall, but the inferior and the anterior wall. Okay, inferior on your left and anterior on your right if you follow the convention in turning your probe correctly. The inferior wall on the left and the anterior on the right. Let's go back. From the 4-chamber view, the second view that you can obtain is the 5-chamber view. So what you're going to do is just, if you're holding the probe like this against the patient's chest, you're just going to tilt it so that it's now pointing more towards the surface of the patient. And what that'll do is, in addition to the 4 chambers, it'll open up the LVOT and you'll also be able to see the aortic valve. So this is what it's going to look like. Both ventricles, both atria. Here's the LVOT and the aortic valve and a little bit of the aorta. So we talked about the 2-chamber already. Here's what the 2-chamber view would look like on an ultrasound. The inferior wall, anterior wall, you see the mitral, and corresponding to the walls, you have the anterior leaflet here, the posterior leaflet here. And you may see the abdominal aorta behind the heart right here. Now, one more thing that you're going to do when you're in the subcostal view is look at the IVC. So when we were in the subcostal view, you remember the transducer marker was pointed to the patient's left. Now, if you counterclock the probe to 90 degrees, and the marker is now pointed towards the chin of the patient, and you move your probe just slightly to the left of the xiphoid, that's where you will appreciate the IVC very well. This is what it's going to look like. You'll see the IVC, you'll see it entering the right atrium. This is a great view to measure the dimension of the IVC and its collapsibility with respirations, and we'll talk about that in a second. So, as you've looked at all these, there are some pre-existing cardiac diseases that you could consider. This RV dilatation, is it acute or chronic? LV dilatation is almost always chronic. If there's biventricular failure, you're probably looking at chronic failure. If the atria are dilated, you're probably looking at either a pressure or volume overload situation. And hypertrophy usually means chronic pressure overload. So as you're looking at these chambers, think this way. Assess the LV shape, the chamber dimension and thickness. Same for the RV. Look at the interventricular septum position. And we'll talk about all this in a second. Then measure your left atrium. We'll show you tomorrow as we're sitting at the machines, how to find the right view, how to freeze the image, how to use a caliper to measure your left atrial diameter at end systole. And that should, the upper limit of that is 40 millimeters, but we'll show you more accurate ways of measuring too. So now that you have the views under your belt, the best way to assess left atrial size is to do a calculation of volume of the left atrium. Now realize these are irregular structures. They're not perfect spheres or cylinders or a perfect geometric shape. They're irregularly shaped structures. So hence, by an echocardiogram and its limited views, you may not be able to have 100% accurate assessment of volumes and functions, but you can get pretty close. And how we do that is by a method called a method of discs that we use in a biplane sense. And let me explain what that means. So what we end up doing is for the chamber, for example, look at this picture down here. We're looking at the left atrium. For this chamber, we divide it into these small segments running across the width of the chamber, okay? So the segments will be the smallest in diameter up here and getting bigger, bigger, bigger in the middle, and then again starting to get smaller all the way down to the smallest one at the bottom. We arrange the long axis from where the valve meets to the middle of the back of the left atrium right here, and we make this division of segments of the entire left atrium. Now then, these are not just 2D segments. We assume that these are perfectly circular, and we stack them on top of each other like imaginary discs. So a small disc, then a bigger disc, and then eventually smaller to the smallest disc on top. So if you were to create a 3D model of this, this would look like a ball with steps for each disc on the side, right? Now, if you're able to look at the same chamber in a 4-chamber view in the apical 4-chamber and then in the apical 2-chamber, then you've looked at a cross-sectional view of that chamber. You have a left to right cross-section and a front to back cross-section. So if you have these 2 sets of discs calculated in those 2 views and you average them, you get a fairly good representation of volume of the chamber, fairly accurate. It's not super accurate, but it's pretty darn good. It almost approaches as good an accuracy as you can get from cardiac MR. So when we apply this technique of biplane calculation using the method of discs to the left atrium, we can approximate the volume of the left atrium pretty good. Here is an actual calculation done for you. You can see this is the 4-chamber view, and we have drawn those discs. And this is like an automatic program. You just you select your axis, you draw the circle around the left atrial margins, and the computer will divide it into appropriate discs, give them standard volume dimensions, and then calculate the total volume for you and throw it up on the screen. So what this has done here is it's calculated the volume of the left atrium in the 4-chamber view. And similarly, now this is looking at the left atrium in the 4-chamber view. You can turn to the 2-chamber view, calculate a volume that way, and you average the 2, you get a very good representation of the left atrial volume. So not only does this help you calculate the volume, now what you can do is, knowing the patient's body surface area, you can index this to the patient. And you can decide if the left atria is normal in size or large. And I want to draw your attention to the left volume indexed by BSA. 34 is about the upper limit of normal, and then anything beyond that is enlarged, where more than 48 is severely enlarged. So if you remember that 34 is the normal cutoff, that's a big step ahead. So that is how we do calculation for atrial sizing, left atrial sizing. The right atrium is a little harder to assess in the same way. So most of the times there's a simpler calculation. Instead of doing a right atrial volume, because it's not the best visualized in 4 chambers sometimes, and in 2 chambers, you're not going to see it at all, right? So the right atrium is hard to get this 90-degree views to do an average of both sides. We're only going to see it in one 4-chamber view as well as we can. The 2-chamber view won't visualize the right atrium. So the calculation of the right atrium instead of volume is just based on area, 1 dimension. And if you calculate the area, you trace the area of the right atrium, the computer calculates it for you. Cutoff of 18 tells you if your right atrium is enlarged or normal in size. Okay, and we are going to do all these things tomorrow. Tomorrow when we meet, we'll go over each one of these calculations, show you how to do these. Similarly, left ventricle can be measured in various views. In a parasternal long axis view, you can measure the left ventricular dimension either in systole or in diastole, end systole and diastole. And the normals are right in front of you. For end diastole, 5.6 is the upper limit. For end systole, 4 is the upper limit. So you can measure the internal dimension of the left ventricle in systole and diastole. And these can tell you if the left ventricle is enlarged or not. Here is an example of measuring these. You can either measure it on 2D image, or you can get an M mode and then measure the M mode distances to get your systolic and diastolic dimensions. But in addition to these measurements, you can also do volumetric analysis for the left ventricle, because that is a chamber you're going to see both in 4 and 2 chamber views. So let's talk about that in a second. But again, trying to show you what we do is we try to measure perpendicular to the long axis of the left ventricle at the tips of the mitral valve. That is the location for your measurement. and you can measure the wall thickness, you can measure the septal thickness, the cavity size in diastole, and then the posterior wall thickness. You can measure all of these three things at the tips of the mitral valve, perpendicular to the long axis of the left ventricle in a parasternal long axis view. And these can help you understand if your left ventricle is enlarged or if your left ventricular walls are too thick. And we'll talk about normals in a second. So the septal thickness, men and women a little bit different, but here they are, upper limits of 0.9 and 1. Similarly, for the posterior wall thickness, about the same, 0.9 and 1. So this can help you understand if your LV walls are too thick. Do you have concentric left ventricular hypertrophy? Do you have asymmetric left ventricular hypertrophy? Or are your wall thicknesses good and you don't have any hypertrophy at all? So this is the cutoffs that you're going to use, and that is the views that you're going to use to obtain those numbers. Again, tomorrow we do all of this hands-on. And then when you try to assess function of the left ventricle, there are some ways in which you can do it. A more inaccurate method is a fractional shortening method or a visual ejection fraction method. But a more accurate method is where we calculate LV volume in systole and diastole, just like we did for the left atrium, we calculated volumes. But here in the LV, we calculate volumes in systole and diastole and compare the true calculated ejection fraction. So let's look at that. First, let's talk about the fractional shortening. So fractional shortening is defined as the left ventricular end diastolic dimension minus the end systolic dimension over the end diastolic dimension, of course, times 100 will give you the fractional shortening percentage. So these were the measurements. I just showed you how to obtain end diastolic and end systolic dimensions. Right here, you're measuring end diastolic in diastole and end systolic in systole. And these dimensions are what you're going to plug into this formula to get fractional shortening. Okay. A normal fractional shortening is 30% or greater. If it's below 20%, that's impaired. And a rough formula is that if you measure your fractional shortening and multiply it by 2, you get a rough EF. But realize this whole thing becomes very unreliable when you have regional wall motion abnormalities, because you're really just looking at those dimensions in one view. So if you have regional wall motion abnormalities, this method is not great. For that, we have to be able to assess EF in a more accurate method. You know, anything below 50-ish% is dysfunction, with moderate dysfunction being 30 to 45 and severe dysfunction being below 30. And then we use the same method, that method of discs, to calculate the left ventricular volume in diastole and systole, plug it into this formula to get a calculated EF. And this gives us a much more accurate assessment of ejection fraction. And here is an example of that happening. Here are 4-chamber views, diastole calculating the LV volume, systole calculating the LV volume, then in 2-chamber view doing the same, and then plugging it into this formula right here to get a calculated ejection fraction. It's, you know, this formula is not hard. It's just diastole minus systole over diastole. So again, you know, this is not going to be a perfect method. It tends to be underestimated in dilated LV, overestimated in a very small cavity of LV. So it's not a perfect method, but this is about as close as you can get and closely follows even MRI calculated numbers. But when you calculate the LV function, always remember, interpret it in the context of drugs that may be on board. Are there vasopressors on board? You know, you might want to repeat assessments serially to assess how function has progressed. If the patient is very tachycardic and atrial fibrillation, that might underestimate the LV function. If the inotropes on board, mechanical supports on board, and that could all play with your assessment of LV function. So know those limitations and what's on board. Now, when you look at this picture, one of the things that you'll appreciate is that it's not the easiest to follow this endocardial border all through. Like here, I don't think I can see the endocardial border very clearly. And maybe here, I kind of imagined it a little bit. So the endocardial border visualization is not always perfect. This is a rather good set of images. Trust me, you get an obese patient, this gets even worse. And what if you are not able to see the endocardial borders? Then you do have an option. There's something called echo contrast, or what it is little tiny microbubbles of fluorocarbon gas that are suspended in liquid form. These little microbubbles are agitated and injected through the IV. And when they enter the cardiac chambers, they're so highly ultrasound reflective that the entire blood cavity of the heart turns super white. It reflects the ultrasound waves like crazy. But what this does is it allows us to see the exact outline of the cavity that is filled by blood. And it allows us to be way more accurate in assessing LV volumes and hence LV function. So if you can't see the endocardial border very well, this is an awesome tool to use. It is quick. It comes in pre-made vials. You just agitate them with a mechanical agitator, inject it into the IV, and your pictures turn up beautiful. And I'm going to show you some examples. There could be almost 50 to 90% improvement in what you can see on the echo images. So here is a non-contrast picture of the left ventricle. And appreciate, there's so many parts of the endocardium you don't barely see. And then you inject contrast, and now you know exactly the cavity of the left ventricle that's getting filled with blood. And hence your volume estimations, your EF estimations can be so much more precise. So using echo contrast is a huge tool in patients where endocardial visualization may not be very good. So again, we're going to use the biplane method. We're doing it in 4-chamber and 2-chamber, diastole, systole, and averaging the two to get a nearly good representation of the EF. Couple of things. You want to do 4-chamber and 2-chamber. We talked about that. You do want to try and exclude the papillary muscles if you can. You want to maximize the LV area. So you want to not foreshorten the LV. The whole of the LV all the way to the apex should be visible, and that's what's going to give you a more accurate number. The long axis goes from the apex to the middle of the mitral valve annulus. So you measure the distance between the mitral valve annulus and plant the long axis right in the middle here to all the way to the apex. And again, you can use contrast for endocardial enhancement when the endocardium is not well visualized. All of these are going to help you get fairly good calculations for EF. So this kind of assessment will get you a good idea of ejection fraction, and then you can couple it with a few other things to understand what your patient might be going through. So next, we're going to talk about some basic volume assessment, understanding volume overload and hypovolemia, and some pitfalls. So severe hypovolemia, if the heart function is normal and you have severe hypovolemia, that ventricle is nearly going to squeeze to an obliterated cavity. The walls are going to really just kiss each other. So that should be one sign that your patient may be hypovolemic. LV and diastolic area of less than 5.5 is an indicator. And of course, it is a variant. The variation of LVDA with loading, which means fluid status, is obvious. But one of the mainstays that you're going to use to assess your volume status is looking at the IVC, looking at its diameter, and then looking at the response to respiration for the IVC. So we measure the IVC in its end expiratory phase. We measure that diameter about 2 centimeters from its insertion into the right atrium. And if the IVC diameter exceeds 2.1 centimeters, that's a dilated IVC. The second thing you're looking for is, with respiration, does the IVC collapse at least half of its diameter and then re-expand? So if it collapses half or more of its diameter with respiration, then that is a responsive IVC. Now, based on the diameter and the responsiveness, you can make a few conclusions. So here is the IVC being measured 2 centimeters from its insertion, the right atrium, front to back, the diameter of the IVC, and watching it in motion as the patient takes a breath to see if it collapses or not, at least 50% of its diameter. There are some pitfalls. Cardiac tamponade and constrictive pericarditis are going to cause the IVC to be dilated and not collapse. And that may not so much be a reflection of volume, but the pathology of tamponade and pericarditis, constrictive pericarditis. So note, these are the pitfalls in assessing your volume status. But barring these pitfalls, this is kind of what you can take home. If the IVC is less than 2.1 centimeters and collapses 50%, you're looking at a normal right atrial pressure. We estimate it about 3. If the IVC is more than 2.1 centimeters and does not collapse, we are looking at a very high right atrial pressure, more than 15. And if you have one of those two features, that is, it's dilated but does collapse, or it's not dilated but does not collapse, then you estimate your right atrial pressure to be somewhere in between of about 8. So remember, 3, 8, and 15, based on normal, one feature present, both features present on the IVC. So that is a way to estimate right atrial pressure, and you're going to use that in of course, understanding your volume loading and in many other features that we'll talk about in a second. So basic volume status, it's very easy to usually understand in severe hypovolemia or clear volume overload, but gets a little harder to assess when there's overlying cardiac disease, you have cardiomyopathy or valvular disease, and respiratory status is compromised, and it gets a little harder, of course. The next thing I want to talk about is measuring the RV function, the right ventricular function. I'm going to talk about two things here. At least one thing that's very easy to reproduce is it's got the fun name of TAPSE, tricuspid annular plane systolic exertion. Okay, and what is TAPSE? So TAPSE is the excursion of the annulus of the tricuspid valve with systole and diastole. How much does it move? Back and forth. And if it moves at least 1.6 centimeters, that's normal TAPSE and signifies a normal right ventricular function. And if that TAPSE is less than 1.6 centimeters, that movement is less than 1.6 centimeters, you can deduce that your RV function is not normal. So what you do is you point your ultrasound probe with looking at an M mode here on the lateral aspect of the annulus of the tricuspid valve, and you look at the movement of the tricuspid valve with systole and diastole, and you measure how much the excursion is from systole to diastole. If this excursion is more than 1.6 centimeters in height, your RV function is normal. And again, I will show you hands-on how to do this tomorrow. Another way to look at right ventricular function would be to look at RV area and compare it with LV area in diastole. So if the RV area to LV area ratio is more than 1, that is usually severe dysfunction. RV can be measured in various views. I think for the sake of helping you focus, I am going to say that your best assessment of measuring RV is in the 4-chamber view, where you measure the base of the RV from the septum to the lateral wall of the RV, and you also measure it in the middle of the cavity of the RV. And the cutoff numbers are right here at the bottom. More than 41 at the base and 35 at the mid-level constitutes a dilated right ventricle. Okay. So here's kind of an example of a dilated right ventricle. You can see huge ventricle here. Just comparing it to the left ventricle, you get a sense that something's wrong. And then when you measure this, it's gonna be bigger than 41 millimeters at the base here, 35 in the middle here. Now, when the RV enlarges, it's usually a combination of a pressure and volume overload of the right ventricle that causes the RV to enlarge. And as this RV enlarges, you can clearly see it's kind of squeezing on the left ventricle. And when this huge RV with pressure overload squeezing on the left ventricle, the septum flattens towards the left ventricle and creates the left ventricle to have a D kind of shape. You see this D shape? So this D-shaped septum is a indicator that you have right ventricular volume and pressure overload. Just trying to show you how to measure RV dimensions, how to measure interventricular septum dimensions. And then the other thing you can look for is the RV free wall on a 4-chamber and measure its thickness. If it is more than 5 millimeters, that is a very thick RV and an abnormally thick RV. And again, that would be usually due to chronic pressure overload on the right ventricle, either in COAD or in chronic PEs or something like that. So another thing that you'll be often called upon is to measure the aortic root. Sometimes if you have an acute presentation of concern for aortic dissection in the ascending aorta, you may be able to catch it on a 2D, or at least diagnose a dilated aortic root so that serial monitoring may happen. Now, the convention of measuring the aorta at the sinus of Valsalva is that it is parallel to the valve plane of the aorta, and you measure it from the leading edge, which is the first edge of the aorta that you see on top here, to the leading edge of the bottom here. So it's not from inside to inside, it is from outside to inside, coming from the top to bottom. Okay, leading edge to leading edge, measurement parallel to the valve at the sinus of Valsalva on a parasternal long axis view, which is where this is measured. You get an idea of measurement of the aortic root. And as you measure the aortic root, you can apply these normograms to understand if your aorta is dilated or not. Normogram C is for patients 40 years or older. Normogram B is for 20 to 40 years. And what you do is, based on body surface area, you put what your measured diameter is, and you can figure out whether your aorta is within the normal range or enlarged. So recommend, there are no absolute values to remember here. You do have to refer to these normograms based on body surface area to understand if your aorta is dilated or normal size. So now I kind of showed you how to measure and look at a lot of things. Now, how are you going to use this knowledge? Well, you get these patients with PEA. Putting an ultrasound probe in the heart is going to tell you whether you got true PEA or not. Or in a code situation, putting an ultrasound probe is going to tell you if you have early return of spontaneous circulation, your heart's pumping. And then you can probably identify now with this newfound knowledge 4 causes of cardiac arrest: cardiac tamponade, hypovolemia, acute PE, and then severe LV dysfunction. So, all of the things we've been talking, you can use this knowledge to come up with these answers as you start applying them. So if you have a patient in shock and you're trying to understand what's going on, it'll be helpful to know if you have pre-existing cardiac disease. Patient with known EF of 10% or severe AS, and you know what you might be dealing with. But barring any pre-existing cardiac disease, evaluate the IVC for volume status. Look at the RV to understand the RV's volume status. Then look at the LV function, and you put these three things together, and you may be able to understand whether you have hypovolemic shock, septic shock, or hypervolemic shock. It may be very easy for you to put these things together in the right clinical setting and reach an answer. Again, how do you worry about pre-existing cardiac conditions? If the LV and LA are both dilated, this is dilated cardiomyopathy, post-ischemic, valvular, or idiopathic. It's likely chronic. This didn't happen just now. Marked LV hypertrophy, that's also likely didn't happen overnight. This is either hypertrophic obstructive, either severe AS, or long-standing hypertension. The right atrium is dilated, and it usually doesn't happen overnight either. That's chronic cor pulmonale. Now, again, remember, we talked about this IVC. If the dimension is less than 21 millimeters and it collapses at least 50%, that is not hypervolemia. So trying to differentiate hypo versus hypervolemic shock, your IVC criteria are important. And then the right ventricle. If it's small and hyperkinetic and there's a large effusion, chances are you're in tamponade. If it's dilated and hypokinetic, you have RV failure. It could be due to LV dysfunction, it could be due to acute MI or acute cor pulmonale in the setting of PE. So when you have dilated hypokinetic RV and you have no other findings to understand and PE looks like a clinically right scenario, then you have just added supporting evidence to your PE diagnosis. Severe LV hypokinesis could be acute MI, it could be sepsis, it could be myocarditis, or dilated cardiomyopathy that's chronic. Hyperkinetic LV, on the other hand, could be acute valvular disease. Acute AI or MR will cause LV hyperkinesia. HOCM will do it, diastolic dysfunction will do it. So, these features can help you understand what your pre-existing conditions or acute conditions may be. When you look at the mitral valve, if there's excessive leaflet mobility, and I'm going to have some examples later, think of myxomatous valve or torn cord A or prolapse or flail, and I have examples of these coming up. This could be in the setting of an MI or a torn pap muscle, and you'll know what you're dealing with. If your mitral valve leaflets aren't moving good, are you dealing with rheumatic or calcific disease, or are you dealing with just bad cardiomyopathy that won't open the leaflets? So as we get together tomorrow and for the residents on the 24th and 25th, we will do some basic valve assessments too. We're going to learn how to get pressure gradients across valves. especially in the mitral valve. We'll talk about mitral stenosis and basic assessment. We will talk about looking at the pressure gradient across the valve. We'll try to do a mitral valve planimetry, and we'll try to calculate mitral valve area with pressure half time. So mitral valve area is 220 divided by the pressure half time. What is the pressure half time? It's defined as the interval in milliseconds where the maximal atrial gradient in diastole comes to half its value. How much time does it take? That's pressure half time. So 220 divided by pressure half time will give you an approximation of mitral valve area. So let's talk a little bit about pressure gradients and MVA planimetry. So as you look at with your probe, you look at the flow across the mitral valve, and you look at the diastolic flow. A and B are two measures of the inflow into the left ventricle through the mitral valve. And you draw an area under the curve when you measure this on your Doppler, and you draw an area under the curve. That area under the curve gives you the mean gradient across the valve. A normal mean gradient is about anything more than 5 is concerning. So if you're approaching a mean gradient of 5 or greater, you have some level of mitral stenosis. And again, we will hold your hands and make you do this tomorrow, and you're going to learn how to calculate mitral valve gradient. But when you look at it in the short axis, on the parasternal short axis view, when you look at the fish mouth view of the mitral valve, you can see how much it opens, and you can trace this outline and do a planimetry. Calculate the area of the mitral valve by planimetry. And this can too give you an idea of how stenosed your mitral valve is, where severe stenosis would be an area of under 1 centimeter square, right? So here are some values for you. Severe stenosis under 1 centimeter square, gradients, mild gradient abnormality is less than, anything more than 5 will be a moderate gradient issue, and then more than 10 would be severe mitral stenosis and corresponding PA pressures that you will record. So these are some of the findings across a mitral valve that can help you diagnose mitral stenosis and its severity. Similarly, when you look at the aortic valve, you can kind of do the same things. You can look at the peak transfer valvular velocity, calculate a mean gradient, and then calculate the valve area by using either the continuity equation, or you may even do a planimetry. So when you assess the flow across the aortic valve, you can do the same thing. If you trace out the curve, you will get what is a good representation of mean gradient across the aortic valve. And a mean gradient of more than 40 is severe AS. Now, I want to show you the difference between these two curves. So in a 5-chamber view, when you're opening up the aorta and you're looking at a gradient across the aortic valve, depending on what you're catching, this is what an aortic gradient would look like. But if you have this late peaking gradient, what we call a dagger shape, then the gradient may not be because of a bad aortic valve, but subaortic obstruction of flow, as in a hypertrophic obstructive cardiomyopathy. And how you can differentiate it is have your patient Valsalva, and the Hocum gradient is gonna go up. Not so much for the aortic valve gradient. So you can differentiate your Hocum gradient with the Valsalva, but the shape of the gradient is also a telltale on the shape of the flow is also a telltale on what you might be dealing with. But here are some aortic valve values that you could be looking for. So an aortic valve gradient of more than 40 is severe AS. An aortic valve area of less than 1 is severe AS. And you can also look at aortic valve velocity of more than 4 meters per second is severe AS. So these could all be some indicators of looking at severe AS. So when we look at the peak of this curve across the aortic valve, that's your peak velocity, more than 4 severe AS. And then you trace this out and you get a gradient, and more than 40 severe AS, okay? Now, one of the common questions you may be asked is to assess pulmonary artery pressures on an echo. And really, this is one of the easier things that you can do, though it does come with a lot of caveats, but when you can calculate it, it can be an invaluable non-invasive tool in assessing PA pressures. You might remember this equation from high school, where if a gaseous or liquid substance is flowing from one area to the other, the square of that velocity times 4 is the pressure difference between those two regions of flow. And you can use this pretty much in all your calculations of blood flow across the heart chambers. So if you have tricuspid regurgitation and you can measure the velocity of that tricuspid regurg, 4V squares gives you the difference in pressures between the right atrium and the right ventricle, right? But this is not the only component of pulmonary artery pressure. The other component is the right atrial pressure. And remember, back to the IVC, we talked about right atrial pressure assessments of 3, 8, and 15. If you add the PASP calculation from TR and the right atrial pressure, you can estimate the pulmonary artery pressure, the systolic pulmonary artery pressure. Okay, so if you have a good TR and you can measure it 4 times V squared, the TR plus RAP gives you a good assessment of pulmonary artery pressure. So here's a quick look. If you have a TR, you point your probe in the right direction, get your TR jet, get the peak velocity, 4 times V squared, assess the IVC, figure out your right atrial pressure of 3, 8, or 15, add it to this number, and that's your pulmonary artery systolic pressure. You can estimate pulmonary artery diastolic pressure by looking at the pulmonic valve. So the PR velocity, the end PR velocity, 4 times V squared that plus RA pressure gives you the diastolic PA pressure. If you're trying to assess the mean PA pressure, you can do 4 times the maximal PR velocity squared plus the right atrial pressure, and that can help you assess the mean PA pressure. You can also do an area under the curve of the TR and assess a mean value that way and add it to the RAP, and you can get a mean PA pressure. Again, these are all things we will do by hand tomorrow. So if some of this is looking a little nebulous, then when you do it on your own, it's going to be crystal clear. All right, guys. Now I want to spend some time sharing with you images that I think are vital to your understanding of echo. So first, we'll go through some sets of images where I will help you with the diagnosis. And then we'll go through a whole set of images where I want you to unmute your mics and let's get into a screaming competition and tell me what you see. Okay, let's first go through some where I want to help you see what I expect you to see. Guys, I'm going to give you 2 minutes to get a drink of water or something if you need, and I'm going to do the same. And so my clock's showing 3:47. Let's resume at 3:50 in 3 minutes with a quick water break, and then we'll continue looking at the Echo Atlas and then go over a whole bunch of images and have a yelling competition on who gets the answer right. 2 minutes, and we'll be back. Guys, if any one of you is here, could you please unmute your mic and let me know you can hear me well? I just changed headpieces. Just want to make sure you guys can hear me well.
Yeah, we can hear you.
Wonderful. We'll resume in 1 minute. All right, guys. Hoping everybody's back. We'll get started. So before we get going with the Atlas, I just want to see if you guys have any questions at this point. Is there anything I can answer? Uh, you can either put it in the chat or say unmute yourself and talk to me right now. We can take 2 minutes to answer questions before we go ahead with the Atlas. Anyone have any questions?
I have one question.
Yes, sir.
So how accurate is going to be the IVC assessment in terms of volume status in patients with pulmonary hypertension and like whatever reason for like RV dysfunction?
So, it's not 100% accurate, of course. It is an estimation, as we noticed. And again, there can be confounding factors. Once you start having pericardial disease or tamponade physiology or ventricular stiffness, uh, these numbers will tend to be skewed some. But this is the best we can do non-invasively. Anything more accurate would have to be an invasive assessment. But it is a great tool still to get an idea of which side of the spectrum you lie on. And as I had mentioned, there was a slide that I put up that it's going to be very clear for you to quickly pick up extreme hyper and hypovolemic situations. It's the areas in the middle with overlying cardiac disease or pulmonary disease where this is going to be a little gray and it is not going to be 100% perfect. But when you evaluate how quick and how handy and how non-invasive this piece of information can be obtained, it's great. I mean, I use it serially sometimes to manage my heart failure patients. Bad heart failure, they want to allow me to put a PA catheter, or I can't for some reason. I'll use daily quick IVC assessments to see where I am. Kidney function is going bad. You don't know if you're doing the right thing. You can't put a PA catheter in. I will do daily IVC assessments, and it'll get me pretty far. So I think it's a great tool to have as long as you understand that there will be some limitations, and it's not an end-all solution. There's still a place for PA catheters. There's still a place for invasive monitoring in the right patients.
Thank you.
Thank you. Anyone else? Any questions I can answer? Okay, hearing none, I'm gonna get going. Let's go over some basic images and look at what we see. So here's a picture where I'm trying to show you how color flow is going to help you understand valve regurgitation. So here you look at it. Again, this is a very subjective assessment when you look at only color flow. There's more ways to measure and understand the severity of MR, but you're getting started on your journey of echo, and starting easy is always a good idea, and then you can build your skills as you go along. So as you look at the easiest thing you can do to assess for cluster valve is throw some color on it. And here you can appreciate, I think, even as a person with not a huge amount of echo experience behind you, you'll be able to appreciate that there's a little leakage into the left atrium in systole. And that doesn't seem like a huge envelope, right? So if you call this MR just based on the color envelope, your chances of being correct are fairly good. So early on, using these color flows to understand the severity of valve disease is a good idea to get an approximate handle of the situation. And then, as I said, going along, you can build your library of criteria in assessing severity of valve regurgitation in a more scientific manner. Again, that is a 4-chamber view, trying to show you mitral regurg in a mild variety in a 4-chamber view. And here is mild MR in a parasternal long axis view. So in a parasternal long axis view, you're looking at the right ventricle here, left ventricle here. This is the aortic outflow, LVOT, aortic valve, aorta beyond it, left atrium here. You can see the small amount of regurgitating jet back into the atria, showing you some mild mitral regurgitation. Appreciate that the flow of the mitral regurgitation is away from the probe. The probe is up here. That flow is going away from the probe. And you remember the convention of blue is going to be going away from the probe, and the right is going to be going towards the probe. And same way here, that mitral regurgitation is directed away from the probe, and hence most of that flow is blue in color. So a quick visual estimation of looking at how bad the mitral regurgitation is. This is now looking at mild aortic regurgitation. As you can well appreciate, this is a 5-chamber view. So what we have done here is taken an apical view where your transducer marker is towards the 3 o'clock position, and you're seeing 4 chambers. You're seeing the left ventricle, right ventricle, and so on. And then you've let your probe handle fall down a little bit so that it's now pointed more towards the anterior body surface of the patient and brings in the LVOT and the aortic valve and a little bit of the aorta. And now this becomes a very good way for you to assess aortic regurgitation. Your best flow is going to be measured when the flow is kind of in line with your probe. So think of it, this is Doppler signal. If it's coming at you, that Doppler signal is much easier to assess because all of the velocity is focused towards your interrogating probe. On the other hand, if the flow is not coming towards the probe or it's perpendicular to the probe, then the flow is the hardest to assess because the vector that is perpendicular to, that is in line with the probe is way smaller and more of the vector is away from the probe. So in this view, in 4-chamber view, when you line it up to the 5-chamber view and look at the aortic valve, usually your aortic flow in and out is lined up to the probe as good as it can be. And this is a good view to assess aortic valve flow problems. Another view that would be really good at assessing the aortic valve, as you can probably postulate, would be the exact opposite of this view. So where exactly can you see the aortic valve in the opposite of this view? It will be in the suprasternal notch. If you can try and get the aortic valve from there, you'll be able to be in line with the aortic valve and assess aortic valve flow problems most accurately. So in this scenario, you're seeing some regurgitation towards the probe coming from the aortic valve and is mostly red in color. Is mostly red in color, and that is mild aortic regurgitation. Guys, you can still see my screen, right? Because I got a notification that your participants can't see and then can see. I just want to make sure you guys can still see my screen.
Yeah, we're seeing it.
Okay, wonderful. So mild aortic regurgitation right here in the 5-chamber view. And how now this is kind of the same situation, but now we are looking at it in the parasternal long axis view. Now you will well appreciate here that the probe is on top right here. The flow direction is perpendicular at 90 degrees to the probe direction. So you know that this will not be the best method to assess the aortic valve flow problems, both stenosis and regurg, because the flow is perpendicular to the probe. And the component of this flow that is in the direction of the probe is rather small. So not the most ideal view to assess mitral aortic flow problems, but again, you can see some aortic regurg in this view. Here, colors make much less sense, and you can see it's actually a mix of colors, red and blue, because honestly, all the probe is seeing is some turbulence of flow, and it's unable to decide whether the flow is towards the probe or away from the probe. Here, we are in a 4-chamber view looking at mild tricuspid regurgitation. So again, this is going to be away from the probe. At the regurgent orifice, there's some turbulence of flow and you're seeing a mix of colors, but most of the flow that's going to be in the right atrium is going to be blue because it's going to be away from the probe. And you can appreciate in this particular view, just by comparator's sake, it looks like the right atrium ain't small. The left atrium is smaller, than the right atrium appears bigger, and there's some TR. So this person may have some chronic right-sided issues. Perhaps we're dealing with some increased pulmonary pressures from obstructive airway disease, just a conjecture. And, you know, this is an example of more severe TR. And here, you can actually appreciate some more things. You see a dilated RV. You see how big that base of that RV is. If you measured it and it's more than 41 millimeters or 35 here in the middle, that's a dilated RV. And you're seeing much more flow, regurgitant flow here than previous. And this is a much more severe TR. And the fact that the RV is dilated probably points to a potential acute problem could be too, because an acute PE would cause something like this. In this picture, I'm trying to show you a left ventricular apical thrombus. Now, if this was a moving picture, what I'm hoping what you would see is an apex that is not contractile. Chances are this could be either non-ischemic dilated cardiomyopathy that is pretty severe, or we are looking at ischemic cardiomyopathy involving the LAD territory, and the apex is dead, it's not moving. So as blood tends to pool in the apical left ventricle, you'll first start to see what we call the formation of smoke, where the blood cavity, instead of appearing black, appears a little hazy and swirly. This is the Roulet formation of red blood cells that is occurring in this apex and is the precursor to forming a clot. Then over a period of time, as clot develops, you're going to see this blunt structure that's more echo-opaque filling the apex of the left ventricle. And this cutoff cavity of the left ventricle is a very typical appearance you will see in a significant left ventricular apical thrombus. You know, left ventricular apical thrombus would be a concerning feature because this is a source for embolization into the left system, of course. So these people definitely need to be anticoagulated for a long period of time. The other problem is, should you need to, you know, this person goes into VT, VF, and you're shocking these people, that can be a reason when you can dislodge this clot and induce embolic emergency. So again, diagnosing left ventricular thrombus will be a key part of your looking at two-dimensional echo. Now, just a little factoid for you to remember, because of how the probe is placed in a 4 and 2 chamber view right at the apex of the heart, this apex of the left ventricle is close to the probe and gets amazingly good resolution. What that means is that this is usually the best way to assess left ventricular thrombus. TEE, or transesophageal echo, is being where the imager is sitting in the esophagus, is far away from the apex. So TEE is actually not a good test to detect left ventricular thrombus. A surface echo is much better at detecting left ventricular thrombus. Now, another thing is that this is a pretty remarkable large thrombus and is easy to visualize with this cutoff appearance of the left ventricle and how dense that clot is pretty echogenic. But on the other hand, should this have been a smaller thrombus, but you saw an apical akinesis and you thought that potentially there's a filling defect in the apex, one of the things you could do is give echo contrast to this patient. Remember, we talked about Optison and Sonic View. These are the fluorocarbonated gaseous suspended missils that you will agitate and inject into the bloodstream. And if echo contrast filled the LV cavity and you had an LV apical clot, you would be able to appreciate that filling defect as a negative contrast, which means that the contrast wouldn't get there, a filling defect where the left ventricular thrombus, apical thrombus is. And that would be a more sensitive test to diagnose an LV thrombus than an echo that you did without contrast. So when in doubt, a contrast picture is going to be a much better assessment of LV apex looking for thrombus. Yeah, just trying to show you the clot, more clot. Okay, so this is a normal parasternal long axis view. I put this here so it would help you identify the structures. As you can see here, the septum, the right ventricle, and the left ventricle. You have the mitral valve leaflets, anterior and posterior. You can see the valve leaflets are pretty crisp and mobile. There's no restriction of the movement of these leaflets. They're very thin. They're not thickened and myxomatous. They're also coapting well, so there's no coaptation issues. There's no prolapse or flailing of any of these leaflets. And the other things that you can appreciate are the dimension of the aorta at the sinus of Valsalva. You'll be able to measure it from the leading edge to the leading edge. You can see the aortic valve, very crisp, opening and closing, thin, pliable valve. The right ventricle doesn't look distended. The wall thicknesses look fairly normal. I mean, I haven't measured them here, but I'm just showing you all the things you're appreciating in this image. And then finally, you'd be able to measure the dimension of the left atrium too. So all of that information you can glean from this picture right here. Now here is the parasternal short axis. And as you can appreciate now, what you're seeing here is the right ventricle. And remember what I was telling you, that since that's the right ventricle, this is the septum. The anterior wall is here to the right side. The lateral wall is here on the bottom. The inferior wall is here to the left side. And what level of parasternal short is this? You can see the papillary muscles. So this is a mid-cavity view. If you didn't see the pap muscles, that would be an apical view. If you saw the fish mouth mitral valve, that would be your mitral level view. If you saw the aortic valve, that would be even higher, looking at the aortic valve view. But right here, you have the papillary muscles mid-cavity view. This view is a rather good, quick assessment of a rough EF. If you visually wanted to call the EF, looking at this would be, you could quickly call a rough visual EF here. And you could also assess pretty much all walls here in the mid-cavity. So if you had a distal wall motion abnormality, you won't catch it here. But mid-cavity wall motion, you can pretty accurately assess it right here. So this is a very quick, nice view to say, hey, normally you have normal mid-cavity wall function. RV is not dilated. It's a lot of information you can quickly glean right here. Sorry, I am not sure why this picture got so pixelated, but I was trying to show you a normal apical four chamber. Can you guys see the picture? It's showing up really pixelated for me. I'm sorry, but
It's okay.
Sorry about that. 1 second, let me see. This is a problem on my end or what's going on? Unsure. Okay, so left ventricle, right ventricle, both valves, both atria, opening of the valves. And if you put color here, looking for regurgitation and stenosis would be possible. Apex assessment is very good. Now, one thing I do want to point out here, see how well elongated this left ventricle is, and you can see the apex. Now, if you tilted your probe a little, you could shorten this left ventricle to be a little more squat. And that wouldn't be a good picture because then you're missing large parts of the left ventricle. And you're underassessing the left ventricle in its cavity size, and volume assessments will be off, and the apex would not be evaluated. So you want to try and achieve as much length of the left ventricle you can in your apical pictures, because anything less in a foreshortened view, you're missing a lot of information. This would also be the picture where you would measure the right ventricular base and mid to assess if the right ventricle is enlarged. This is also the picture where you would measure the area of the right atrium to tell me if the right atrium is enlarged. This is also one of the pictures where you will look at the volume of the left ventricle and the left atrium to give me left ventricular volume and left atrial volume, and hence assess left atrial size. And when we combine this information with systole and diastole and 2-chamber and 4-chamber, then you'll be able to tell me what the LV function is. So these are all the things you would glean from this picture. In addition, the walls that you're seeing, the septum and the lateral wall. So if you have an acute MI in a patient who you suspect has a SIRT territory infarct, your lateral wall is hypokinetic, that's how you're going to be able to confirm your diagnosis on a quick echo. Now here's a 2-chamber view. Now notice here, what has happened is we have turned the probe 45 degrees counterclockwise, right? where the marker wasn't previously on the left side. Now the marker is kind of pointed more upwards. So when you turn the probe counterclockwise 45 degrees, no longer do you see the right-sided chambers. That is the way you know that you have effectively achieved a good two-chamber view, is you no longer see the right-sided chambers. You're only seeing the left ventricle and the left atrium. And by convention, if you've done this right, this is the inferior wall, this is the anterior wall. Okay, I remember it as two-chamber T, I on the left, A on the right, TIA. I just remember it like that. This is my mnemonic, but if you want to remember it any other way, feel free. Inferior on the left, anterior on the right, in a two-chamber view, when you've done the conventions right. So what all can you see on this picture? Of course, you can see the apex, just like you would on a four-chamber. But here now, if you were trying to assess inferior or anterior wall motion abnormality, this would be your view. If you're trying to look at the volumes of the left ventricle and left atrium in two-chamber view for either left atrial size or LV function assessment, you would do it here. And of course, the mitral valve also you can assess here. Here, you have the anterior mitral leaflet towards the anterior wall, the posterior mitral leaflet here. The pap muscles are very well visualized. Any regurgitation would be well visualized, and you can see part of the left atrial appendage right here. So this is a contrasted picture. And what I'm trying to show you is that if you did a short axis view in the mid cavity, you would think the walls are squeezing great. But this is a person who's had a distal LAD or mid LAD infarct, and the apex and the distal segments are fairly akinetic. This is a person who's at a risk of developing an apical clot. And if your patient came with ST elevations in the anterior leads and you just did a mid cavity evaluation and said, oh, no, all walls are moving good, you missed something. You had to do an apical look to see that the apex is out. So trying to show you when the LV cavity is so enlarged, this is a person with dilated cardiomyopathy, your annulus has enlarged. So very central directed mitral jet, mitral regurgitant jet. Here is not an indicator of mitral valve pathology, but this is functional MR because the annulus is stretched, the valve leaflets don't coapt so well anymore, and you get severe-ish mitral regurgitation, which is functional in nature. This is a look at an aortic valve that is bicuspid. If you see here that you don't see any separation of the leaflets at this third commissure, and you really just have two leaflets opening and closing bicuspid aortic valve. This is a person who's likely to develop aortic stenosis somewhere in midlife and might have a dilated aorta. So the next thing you want to do is assess the aortic size as well. Trying to show you a patient with AS, you can see the calcified aortic valve with very limited mobility and how it contrasts with a previous image where I showed you in this parasternal long axis, how thin, pliable aortic valve leaflets opened and closed so well. Here it doesn't open and close so well. It has a restricted movement, it's calcified. And when you put a Doppler across it in 5-chamber view, you can get the aortic flow velocity from here and measure the maximum velocity if it is more than 4 meters per second, or if the area under the curve is a gradient of more than 40 millimeters, then you're looking at severe aortic stenosis, time for a valve replacement or surgery or TAVR, whatever. So just trying to show you again, severe aortic stenosis, the observant of you would have already seen how thick the LV walls appear. So this has been an aortic stenosis for a while, and this is LVH that is developed because of the ongoing aortic stenosis this patient has been dealing with. This is a picture of the descending aorta, and many of you can tell me right away, hey, there's something inside the aorta floating right here. If this patient came in with the right symptoms, this is an aortic dissection in the descending aorta. If you put color on it, you would probably see flow in the main lumen and in the false lumen too. This is aortic valve endocarditis. You can see something attached to the aortic valve flopping in and out. In the right setting, this would be someone who might need an aortic valve replaced. So if you measured this aorta here I'm sure even without measuring, you can tell me there's all these dots tell you is a very dilated ascending aorta. If you put color on this, chances are this patient would have AI. This is a very dilated aorta, ascending aortic aneurysm, a large pericardial effusion. You can see the swinging of the heart, large pericardial effusion, swinging of the heart. In an EKG, anybody wants to tell me what phenomena this will produce on an EKG?
Pulse.
I think you guys said electrical alternance, and that would be the right answer. So how do you diagnose tamponade by 2D echo? First, of course, you'll see the large pericardial effusion. You'll see the heart swinging. You might see a diastolic atrial collapse. That is an early finding of tamponade. And here is a picture showing you a diastolic right atrial collapse. But the definitive finding is an early RV diastolic collapse. The right ventricle in diastole will have this dip, this collapse. If you ran an M mode across here, you will see here is systole, here is diastole, and then this dip, this early dip in diastole, the RV wall collapsing in diastole. That is diagnostic of tamponade, of course, in the right clinical setting. And the IVC should be dilated with reduced collapsibility to go with it, right? Let me ask you, let's say you have tamponade findings, large effusion, dip and all that, but your IVC is squeezed and almost nothing. What are you gonna do? Anyone?
Give fluid.
Fluids, because that is a state of hypovolemia. And your tamponade may not necessarily be because of the pressure from the pericardial effusion, but may be because of lack of intravascular volume, and replacing the intravascular volume is going to get your patient out of trouble way faster than poking a needle through his chest or her chest. But the next thing that you can do an assessment of your assessment of tamponade is to check for Doppler flow across your mitral and tricuspid valve. So you're going to point your Doppler at the mitral valve and the tricuspid valve and look at the Doppler flow. With inspiration, as you can all physiologically tell me, that the tricuspid flow, the right side flow will increase and the mitral flow will decrease, and the opposite is going to happen in expiration. This is normal. But if this variation in change of flow between inspiration and expiration exceeds 25% in mitral and 45% in tricuspid, and some say 40%, so you can choose either. So 40% and 25%, or 45 and 25%, whichever. If it exceeds that between inspiration and expiration, that is an indicator that you now have tamponade physiology. So you measure the peak flow in inspiration and in expiration, and you see the difference between the two. In mitral, if this difference is more than 25 or 40 in tricuspid, that is tamponade physiology. I want you to appreciate here, this is a two-chamber view. Inferior wall is here, anterior wall is here. Well, it's globally hyperkinetic, but the inferior wall is nearly akinetic, doesn't move. You can see that here. Okay, another example of an LV thrombus. You guys have seen this now before. I'm trying to show you this mobile-looking thrombus right here. That's a little concerning. It's kind of pedunculated and moving around a little bit. These are the guys who embolize and cause a lot of trouble. This is a normal IVC response. I want to show you. It's a thin IVC that nearly collapses with respiration. And here is an abnormal IVC that's dilated and won't collapse at least 50% with respiration. This is an RV pressure volume overload situation, trying to show you a D-shaped septum, enlarged RV, hypokinetic. This is a patient with mitral stenosis. Sorry. Oh, sorry, one plate. So essentially showing you how turbulent the inflow through the mitral valve is. You see the doming of the leaflets, that fluid, the blood is really trying to squeeze its way out, and how turbulent that flow is. And over a period of time, your left atrium is going to enlarge if you have severe mitral stenosis. This is an extreme case. Left atrium is like a tennis ball size atrium, and everything else is kind of dwarfed by the size of the left atrium. Trying to show you, trying to show you eccentric MR versus central MR. See how this mitral regurgitation is hugging the wall and can be underestimated if you're not seeing the eccentricity. And this is more central MR. Central MR, more likely maybe functional. Eccentric MR is usually a valve pathology. One of the leaflets is bad. Tamponade. Have some better examples of tamponade that I can show you in a second. Here. So watch here now, the free RV wall and diastole, that little dip that comes about, that's pretty concerning for tamponade. Showing you an example of severe TR. I think all of you have now noticed this right atrium is huge. That TR is pretty bad, wide base, pretty severe, hitting the back wall. Trying to show an example of right ventricular hypertrophy. If you measured the thickness of that right ventricle, anybody's going to tell me how thick that right ventricular free wall needs to be to call this right ventricular hypertrophy?
5 mm.
5 mm. That's the right answer. Showing you a little bit of AI in the 5 chamber. Again, just familiarizing you with the images as you will see them tomorrow. Trace AI. Looking at LVH, thick left ventricular walls. We'll measure these. If they're more than a centimeter, chances are you have left ventricular hypertrophy. This is an example of mitral valve prolapse. You can see here, anybody can tell me which leaflet is prolapsed here? Is it the anterior or the posterior? You have a 50-50 chance of being right. So if you think
Posterior?
about it, posterior is the right answer. And why is that? Because remember, the aorta is right here. This is the anterior leaflet right next to the aorta. And this is the posterior leaflet, and you can see how it is prolapsing into the left atrium. This on Doppler is going to have significant mitral regurgitation. This is the MV prolapse. Showing you an example of pap muscle rupture, post-MI. You can see the pap muscle is still attached to the leaflet by the chordae and swinging freely in and out into the atrium and ventricle. That's not good. Okay, this is PE. You guys have heard the fun term McConnell sign. Dr. Gohar, I think, referred to it too. The apex of the right ventricle is contracting normally. The free wall is hypokinetic. The RV is entirely, function is down and dilated. This is acute PE, McConnell sign. Looking at pulmonic insufficiency, pretty significant. So this is a part of the parasternal short axis, where this is the aortic valve. Tricuspid valve would be here. This is the right ventricular outflow tract, pulmonic valve, pulmonary artery, just trying to orient you guys. Okay. An example of dilated cardiomyopathy with contrast images. This is an example of lateral wall akinesis. Someone who had a circumflex infarct, perhaps. You can see the septum's doing okay, the apex is doing okay, but the lateral wall is pretty dead. So you can see the serpiginous tract across the ventricular septum, interventricular septum. This is very typical. The serpiginous tract is very typical for ventricular septal rupture after an acute MI. Usually an emergency, needs surgery. Non-Doppler and Doppler images showing you the flow, and here just showing you the serpiginous tract. good example of severe LVH with some asymmetry and probably some outflow obstruction. As you can see, I'm going to try and see if I can pause this image. No, probably not. It won't let me. But you can see in systole that the cavity kind of nearly obliterates at this point, and this part of the cavity further down is almost isolated from this obstruction. So this is mid-cavity obstruction. This is obstructive cardiomyopathy. And a couple of things that happen with obstructive cardiomyopathy is in systole, you're going to see the movement of the mitral valve towards the septum. It's called the systolic anterior motion of the mitral valve, the SAM. You know, the mitral valve leaflets move towards the anterior wall, kind of even dip towards it like this and come in the way of the outflow tract, worsening the obstruction. So SAM, or systolic anterior motion of the mitral valve, will worsen the outflow obstruction because of the mitral leaflets coming in to the outflow tract like this. But this distortion of the mitral valve then causes a posteriorly directed mitral regurg. So not only does it worsen the outflow obstruction, there's now going to be some MR. You can see here now a good example of how the mitral valve is bending towards the anterior septum. So SAM coupled with some MR, worsening the outflow obstruction, typical of HOCM. All right, this is kind of the images that I had for you here. I'm gonna now switch to some more images where I want you guys to participate. So give me 1 second as I switch screens, and we will be back. I think this is it. All right, people. Okay, so I think I want, let's do this. Let's find a way to do this. How about, let's go institute by institute. How about the KU fellows, unmute your mics if you're still here. And the next two images, I want you to tell me what you think you see. So what do you think is on the screen right now?
Chamber view, the RV enlargement.
Notice the apex of the RV here. Watch this.
Yeah.
And you see the rest of the lateral wall. What do you think's going on?
It's a PE probably.
Very likely PE. This is a McConnell sign. You're absolutely correct. Good work, sir. All right. What do you think we're seeing here?
Parasternal long axis view. We can see there is an effusion. It's above the descending aorta.
Wonderful. Yeah, you're making absolutely correct observations. You see the descending aorta, so this is likely a pericardial effusion. But here, look at the free RV wall here, and in diastole, you see that little dip, early diastolic dip. This is the likely tamponade, but you're right on, sir. Very good work. Very good work. Okay, let's do one more with you guys, and then we'll switch people. Parasternal long axis.
It's a little AI, I think.
It's definitely AI, but here's one more thing. Look at the aortic dimension here. You see that? That's more than 5 centimeters right here, if you believe this scale. So that is a significantly dilated aortic root, and hence the AI with it. But you were right to pick up on the AI, and the one more thing to pick up here is the severely dilated aortic root. Excellent work. Very good. Thank you so much. Let's move to the UMKC fellows. Let's look at the next couple of images. UMKC fellows, if you can unmute your mic and feel free to comment on the next set of images.
Dilated non-compressible IVC.
Perfect. Easy. You guys are getting good at this already then. Mm-hmm. All right. What do you see here?
A collapsing LV and then a enlarged RV.
Very enlarged RV, D-shaped septum, RV pressure volume overload, squeezing on the left ventricle. Perfect. How about this one?
That looks like a thrombus or something on the wall or on the valve.
Yeah.
Like
So
somewhere.
typically, yeah, typically if it's attached to the leaflet and so mobile, I would think thrombus is unlikely. But you're right, something attached to the valve that shouldn't be there. My possible diagnosis would be a vegetation in the right clinical setting. This looks like a large vegetation to me. Hey, again, the clinical setting would really help understand what you're looking at, but very likely a large microbial vegetation. So spot on there, very good work. Let's do one more with you guys.
It looks like a calcified aorta.
It's actually the same guy. It's that anterior mitral. Yeah, this is that anterior mitral leaflet vegetation only now seen in short axis in that fish mouth view, versus here you were seeing it in a parasternal long. This is the parasternal short axis view. Pretty much the same guy. Good work though. Yeah, I mean, I kind of think you have that. All right. Do we still have MU fellows here? Any of the MU fellows still on there? Wonderful. If you'll unmute your mics, let's go over the next few pictures with you guys.
So left ventricular apoikinesis, Takotsubo, maybe?
Actually, no. If you look hard enough, that apex is squeezing okay. I will say this. I'm sorry. This is a little harder one. So no negative points for not getting this. What this is actually, you can see here, this is struts of a mechanical valve. So this is a mitral prosthetic valve. I'm sorry, a little harder one. Okay. The LV is squeezing okay though. Sorry about that. Okay, how about this one? This is an easier one. Parasternal long. Somebody with fever.
Is it dilated right ventricle?
So I was trying to point your attention to the aortic valve. There's something hanging off that valve that is not normal in structure. This is aortic valve vegetation. Okay, the answers here. This is not a question, just trying to show you an interesting picture. That look here, this entire anterior mediastinum is so wide in a patient post-trauma. This is anterior mediastinal hematoma. The heart's doing okay in the back, but it's now getting to be compressed by the hematoma in the anterior mediastinum. Just want to show you, it's a fun picture. Okay, what do you think of this?
Thrombus.
Thrombus in transit, almost, right? It's kind of flopping in and out. You can see a part of it in the ventricle here, part of it in the atrium here. Massive thrombus. This is a bad PE about to happen. Okay, let's do one more with you guys. Actually, not a very clear picture. So let me skip this one. How about this one?
Yeah, hyperdynamic, fluid down.
Hyperdynamic, absolutely. So could be hypovolemia, could be something else causing hyperdynamic state, but this is hyperdynamic LV, and that's what I wanted you to pick on. Can I do one more with you guys?
Sure.
Yes.
Okay, what do you think? So this, when you see homogeneous appearance of tissue like this with venous tracts in between, start thinking that you're looking at the liver, and that should be your clue to tell me what this is.
IVC thrombus.
Massive IVC thrombus. Absolutely correct. Good job. Excellent work, guys. Excellent work. Okay. UMKC residents, if you're still here, unmute your mics. We'll do the next few with you.
Volume down.
Volume down. Perfect. Say no more.
aorta appears enlarged.
Say that again one more time.
Aortic aneurysm, or the aorta looks larger.
Looks like
Actually,
aortic stenosis.
okay, so
LV
everybody, this is a very interesting echo, okay? The pathology is one, but the findings are many. So aorta is not enlarged. If you look at the markers here, these are a centimeter marker, and this aorta is less than 4 centimeters, so not enlarged. But look at this aortic valve, super calcified, barely opens, right? This is bad aortic stenosis. But this is bad aortic stenosis that's been around for a while because the LV is down. And look at the mitral valve, it's barely opening. The leaflets are not abnormal, but the mitral valve is barely opening because of severe aortic stenosis and LV down. This is just a low flow state now. So severe aortic stenosis, low flow state. Very interesting echo finding, I think. For the echo enthusiasts in you, you should be clapping your hands.
So little.
Yeah. Sorry, I have another one of this. Let me keep going. What do you think?
Bicuspid aorta.
Bicuspid aortic valve, aortic stenosis. Good work.
Vegetation. They're on the.
Very right. On the mitral valve. Very good. Who picked that up? Can I know your name?
It was Katie.
Katie, good work. That is very good. Right there.
Same thing.
Same vegetation.
Actually, D-shaped septum. I was trying to show you that D-shaped septum in Cicely. See that? That's a papillary muscle, guys. Don't get confused. Pap muscles. Do them. Okay, last one for you guys, and we'll trade teams. This is the left ventricle.
Not moving.
Not moving. Well, actually, that is the diagnosis. It ain't moving. It's probably asystole.
It just looks like a snowstorm.
Absolutely. Do we have KU residents here? Nope. MU residents?
No residents from KU or
No.
MU. Okay.
MU? No. Okay. All right. Back to KU, fellas. You ready, guys, for some more? And we're wrapping up almost. Time to go home. Well, you're already home. Time to go and play. What do you guys think?
Long axis, left atrial enlargement.
What if I told you this guy's from India and had fever when he was young?
Mitral stenosis, they are now converting to MR.
Yeah, so look at the
mitral
hockey stick appearance, trying to show you rheumatic mitral disease. Okay, this one's hard. I'm sorry, the picture's not great. But
the huge, it's a parashar long hypertension.
Massive right ventricle. You got it, sir. Good work. Okay, this is a good one. You're gonna feel good about diagnosing this one.
I can't even make out the view actually.
Doesn't matter.
With a needle coming in?
Yeah, good work. So where's this needle going? Pericardial space, yes. So moving structure, heart, pericardial space, needle going in. This is pericardiocentesis in the happening. So if you did a pericardiocentesis guided by echo, this is what it would look like. So this was a bonus. Good work for getting that. I'm trying to show you hypertrophic obstructive cardiomyopathy. Near collapse of the left ventricle. Start to see a little SAM. This is going to be obstructive pathology. Okay, who wants to get this one? This is a good one. Okay, you guys, you're up still. What are we scanning here? What structure are we scanning in this pulse wave Doppler?
Mitral valve?
Absolutely. And if we're scanning the pulse wave Doppler of mitral valve and you're seeing this, why are we doing this?
Mitral stenosis?
Inspiration, expiration difference in mitral inflow. 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 Mitral inf
Respiratory variability for tamponade physiology.
You are right on, sir. Good work. Very good work. And this is a more than 25% difference in mitral valve inflow pattern velocity and likely congruent with tamponade findings. You know what? I think we've been through this before, but this is there are two things here. One is more obvious and the other is a little subtle. This is a very interesting finding. I will say if you answer this one and I see you tomorrow, let me buy you a special lunch.
Is that a pacemaker lead?
Dude, you're right on it. That is a pacemaker lead. What else do you see in addition to a pacemaker lead? You're biting the nipping at the heels here. What else do you see?
Again, pericardial effusion.
What's this?
Pericardial effusion.
Okay, now put the two together. Pacemaker lead, pericardial effusion. What's going on?
Perforation. Pacemaker lead perforation.
Lead
Pacemaker lead.
perforation. And you can actually see this lead go all the way out there. Can you see that? All right. Who was that? Who got this? First, pat yourself on the back. And two, can you find me tomorrow? I owe you something. Good work.
Asystole?
You could call it that, but if you were more discerning,
Quivering? Myocardium?
quivering. So when does myocardium quiver?
When it's stunned or when the
I think the pup in the back knows the answer. He wants to answer. This is VF, ventricular fibrillation. Yeah, you can call it asystole, I guess. But you can see that the ventricles are in a quiver state. This is VF. Wonderful.
papillary muscle rupture?
So I think we're looking at the right side of the heart here. Without a clinical scenario, I can say that if you called it papillary muscle rupture, I could say no to it. But this is the right side of the heart. Chances are this is a large thrombus or vegetation, right? More likely. All righty, this is a good one. Somebody make a try. UMKC fellas?
Is that a large effusion with like fibrinous material?
You're absolutely correct. So this is a lot of fibrinous material stuck to the surface of the heart in a large pericardial effusion. You are absolutely correct. McConnell sign again. Apex is contractile, lateral walls pretty hypokinetic, large
Is there
RV.
thrombus in there too?
I think what you're looking at is probably RV moderator band. But I can't, I have to say that it wouldn't be, with just this one image, it would be hard to say. So good pickup. These are massive thrombi in the right and the left ventricle.
This person has like no EF.
Correcto. So if you're trying to do pericardiocentesis by needle under echo guidance, once your needle enters the pericardial space and you want to confirm you're in the right place, especially if you get a bloody drawback and you don't know whether you entered the heart cavity or you're in the pericardial space, you can inject some agitated saline bubbles that'll show up under echo as echo bright. So this is bubbles injected in the pericardial space while trying to do pericardiocentesis, how you confirm that you are in the pericardial space. Interesting, right? This is agitated saline being injected to assess for if there is any atrial septal defect, and these bubbles go across to the left side. Okay, anyone? First tell me what view is this and then tell me what you see. MU fellas?
Substernal notch.
Suprasternal notch, yes. And what do you see?
Dissection.
Aortic dissection, right? That's what you said?
Mhm.
Wonderful, wonderful. Large effusion, moving heart, another effusion. Large vegetation.
VSD?
Large vegetation, floater, right in the middle of that. Huge vegetation. Pretty collapsed IVC. I think that's kind of what I was trying to show you. Not a very clear picture. I'm gonna ignore this one. What do you see here?
Yeah, maybe. Yeah.
So you have a device lead,
Pacemaker lead vegetation.
yeah, with potentially an associated thrombus. Yeah, good work, good pickup. All right, guys, that's kind of all I have for you. Thank you so much. I really enjoyed talking to all of you. And I'm looking forward to meeting you over the next few weeks. Some of you tomorrow, and some of you in 2 weeks. I'm open to any questions right now, and otherwise excited to get your hands on to the Echo machine.
Great lecture, Dr. Baweja. Very, very informative and wonderful videos.
Thank you, sir. Thank you for listening to the whole of it. I'm sorry I was lazy and I didn't listen to the whole of yours.
It's okay.
I'm sorry about that.
I personally learned a lot from that, and I'm
thank you
sure
so much.
everybody enjoyed it. And thank you everybody for being interactive and part of the lecture with Dr. Baweja. I think smart people, and they picked great answers.
Absolutely. I'm actually impressed with your observations and you know how quickly you're applying what you've heard to the pictures you're seeing. Excited to see what's going to happen tomorrow. So guys, thank you so much for being here. Looking forward to meeting all of you in person tomorrow and in the coming few weeks. And get some good sleep, because tomorrow's going to be a busy day. Lots of stations for you to practice, 3 on the cardiology end, 3 on the pulmonary end. And tomorrow's menu is butter chicken for the non-vegetarians. And for the vegetarians, I think it's going to be a paneer dish. So this is Indian food. Hopefully you'll look forward to the lunch too.
Probably this is the best part of the course.
Oh, butter chicken sure is. I'm looking forward to it. All right, guys, thank you so much.
Hey, Dr.
Yes,
quick unrelated question. Do you still review resident contracts?
I do. For the last 5 or 6 years, as most of you may know, and those from KU and other places may not, I do a business of medicine course for the residency program. And over the last 8-9 years, I've been reviewing residency contracts and fellowship contracts. With an average of about 8, 9 to 10 a year, I am over 100 contracts reviewed. I keep myself updated on this and can advise you, and it's a free service to anyone. I happily extend it to the KU and MU folks who are here. If you ever want me to review a physician contract for you, it would be my pleasure to look at it and give you some comments. So anyway, anyone who wants to avail that facility, you have my email, you know how to get in touch with me. It would be a pleasure to do it.
Thank you so much.
Thank you.
Great. Thank you, everybody, for joining us, and see you tomorrow or 24th and 25th for the residence.
Thank you, Dr. Baweja and Dr. Gohar. Have a good one.
Thank you, Dr. Gohar. Thank you so much. Thanks, everyone.
Thank you all.
Have a good evening. Thank you.
Bye.